we have a full day ahead of us, and we are streaming live now on Zoom, on YouTube, from our Zoom here at the Committee on Health Coverage Insurance and Financial Services. And on our docket for today, we've got a presentation from the MHDO with regard to their prescription drug transparency report. And then we have 4 work sessions. And then I think we have some budget discussions to wrap up our day today. At some place in there, depending on how the day unfolds, we will be taking a lunch break. And I think that's the plan. So I want to start with committee introductions, as we do. And we'll start today with Representative Matheson.
Good morning. My name is Christy Matheson. I represent District 1, Kittery.
And Representative Quint.
Good morning. I'm Tracy Quint. I represent House District 144, which is the Greater Holton area.
Representative Arford.
Thank you, Madam Chair. I am Representative Poppy Arford, and I serve District 49 in the western part of Brunswick.
Representative Malrano.
Good morning. My name is Gina Malrano. I represent House District 62, which is part of Auburn.
Representative Blyer.
Can everyone hear me?
We can.
Can someone talk? Because I don't hear anybody.
We can hear you. We can hear you.
I can't hear you. Okay, hold on.
Yeah.
I got to do something different here.
Okay. We'll go to Representative Evans. All right, not a great start for us today. Representative Brooks.
Good morning. My name is Heidi Brooks. I represent House District 61, which is part of Lewiston.
Thanks. Representative Evans, can you hear us now?
I can hear you now. Thank you.
Great.
I'm Richard Evans. I represent House District 120, including Dover, Foxcroft, Atkinson, Brownville, Medford, Milo, Plantation, Lakeview, and Hunterville Township.
Thank you, Representative Evans. Representative Blyer, are you with us?
I am. Thank you, Madam
Great.
Chair. Sorry about that. I'm Representative
No
Mark
problem.
Blyer, representing District 22, which is Leamington and part of Standish, Buxton, and Limerick.
Great. Representative Morris.
Yes, good morning. I'm Representative Joshua Morris. I represent the towns of Turner, Leeds, and Livermore, House District 75.
Great. Representative Tepler.
Good morning, and thank you, Madam Chair. I am Representative Denise Tepler. I represent House District number 54, which is all of the town of Topsham, and I serve as House co-chair of the committee.
Great. And I'm Senator Heather Sanborn. I represent Senate District 28, which is half of Portland and half of Westbrook. And we are assisted today by Christian Ritchie, our clerk, and by Colleen McCarthy-Reed from the Office of Policy and Legal Analysis, who has done absolutely incredible work to get us ready for our work sessions today. So thank you so much, Colleen, for the late night work that you assisted us with over the last little bit. Okay, so without further ado, I want to turn to a presentation from the MHDO from Karen Lee Harrington. So we'll pull her into the meeting. And we'll wait for her to arrive. There she is. Good morning, Ms. Harrington. Can you hear us? There she is.
Morning.
Good morning. All right, great. So I'm not sure if Colleen's going to be screen sharing for you, if there's some slides, but I'll let the two of you take it away.
Colleen, do you want to do that, or do you want?
If you have slides that you want to share, that's usually how they do it. You can send them to me and I'll share it. I can also pull up the report, whatever you want.
So the deck I sent last night, I can resend that.
Okay, because I didn't get it. So.
Oh.
Yeah, I didn't either.
That's not good.
At least I don't think I did.
My apologies. Just give me 2 seconds. Sorry.
No problem.
Okay, I just sent it. And while it's on its way, let me just say really quickly, I've asked Jim Jones, who is our consultant and technical expert, to tag team this presentation
Great.
with me. So I'm
We can
gonna,
bring him.
that would be perfect. I was just gonna say, I think he's on.
Yeah.
And if okay, the way we're gonna work this is I'll talk through the first handful of slides, and then I'll transition it over to Jim, and he'll really talk through some of the key findings and some of the more complex issues that I'm still wrapping my brain around and not as confident yet in the subject matter. So Jim really is our expert, and he will run point on that.
I still haven't
Great.
received your slides, Karen Lee. I don't know if maybe if you send it to HCIFS at legislature.gov, that might be easier, and legislature.maine.gov, and then Christian can send them to me. I don't know why I'm not getting it. Sorry.
No, I'm sorry. I'm embarrassed that we're wasting this time. I could have sworn I did it last night, but again, my apologies. So in the interest of time, I just sent it to the HCIFS address. Let me just start off by saying that the presentation, and Senator Sanborn, let me confirm, do we have about 20 minutes or so?
Yes, about that. We can go a little bit over with questions, but if you want to hold your presentation to about that, that would be great.
Okay, perfect. So I'm gonna start the watch here to make sure that I don't go over, and can give Jim the time that he needs to get through some of the substantive issues regarding our first report. But I want to just take a minute to level set. I know you've heard me talk about the role of MHDO, but I think it's just good to repeat it because you're busy you've got a lot of agencies and programs that you're responsible for. So our purpose really is to create and maintain a useful, objective, reliable, and comprehensive health information data warehouse that's used to broadly improve the health of Maine citizens. And we're responsible for promoting transparency of the cost and quality of healthcare, including prescription drug cost information. And this really, over the last couple of years, through different bills that the legislature and governor have passed, has really become a huge part of what we do in terms of transparency, is really focusing on the costs of prescription drugs in our state. And so what we're going to talk about today is a report that we're required to put together based on some of the data that we collect. And just as a reminder, we collect all different kinds of prescription drug data. We get data out of our all-payer claims data that includes medical and prescription drug information. And then we get prescription drug cost information from manufacturers, wholesale drug distributors, and pharmacy benefit managers. And the first year of data that was collected from these reporting entities is for the time period. Excellent. I see the
Where are we?
is
Got it
up.
up.
So
which slide do you think you're on?
We are on slide 3. Perfect.
There we go. Okay. Everybody see that? Great.
Thank you, Colleen. So for this first year of data, from the manufacturers, wholesale drug distributors, and pharmacy benefit managers, is for the time period September 2019 through December 2019. Year 2 will be based on calendar year 2020, which we are currently in right now. Next slide. So just to level set, I think the reason why, right, you hear from your constituents regarding the cost of prescription drugs and why this is over the years continues to be an issue is if you look at the percent of pharmacy paid as a percent of our total medical paid, you know, it's been going up over the years. I remember before I came to state government, which is hard to believe, but this will be, I think, 18 years that I've been in state government. Prior to that, I was in the insurance industry for 13 years. And prescription drug costs were somewhere around 15% of total paid. And you can see now in 2018, 2019, 35% of total payments. Next slide. So Public Law Chapter 406, which was the first law that was passed that required MHTO to promote prescription drug price transparency requires that we report on the 25 most frequently prescribed drugs, costliest drugs, and the 25 drugs with the highest year-over-year cost increases. Those reports are available on our website, Compare Maine. And it's important to show sort of incrementally, right? This was the first step, was reporting the top 25. And then next slide. This is just a screenshot of what the report looks like on Compare Maine. So you have the ability to go in and select whether you want brand, generic, both. You can select payer type, and then you'll see the ranking of the drug, the NDC number, which if you look up the NDC number, it will tell you who the manufacturer is, the quantity, the type of, the way the drug was dispensed, whether it's pill or not a pill form, the drug name, the drug class. So we're trying to give you a sense of what the drug is used for, the number of prescriptions for that particular drug, the number of prescription users in our state, and then the cost associated with a state total, as well as then the top 25, and then the cost per prescription. And so again, this is just a screenshot, but we're doing this for, again, the most costliest, the highest utilized, and then those drugs with the greatest year-over-year increase. Next slide. So the next step was you passed, or the legislature and governor passed Public Law Chapter 470, which was a further expansion of drug price transparency. And this is where we're required to collect data from, again, the prescription drug manufacturers, wholesale drug distributors, and pharmacy benefit managers. I'm going to refer to them going forward as reporting entities. And Rule Chapter 570, which I know you're familiar with and you're addressing now, is the rule that governs the submission of this data. Next slide. So this law requires a prescription drug manufacturer to notify the MHDO when the manufacturer in the previous year has, and then you'll see the three triggers: increase the wholesale acquisition cost of a brand name drug by more than 20%, increase the wholesale acquisition cost of a generic drug, and you'll see the specifics there, or introduced a new prescription drug. So those are the triggers that would require the manufacturer to notify MHDO of that particular drug. Next slide. So MHDO is required to take this information and produce an annual report that we are to submit to you all beginning November 1 of 2020. And the content of the report is supposed to be around information on trends in the cost of prescription drugs. Again, based on the information that's coming from these entities. Analysis of manufacturer price and price increases. Major components of prescription drug pricing along the supply chain. Impacts on insurance premiums, what people are paying out of their pocket. And then other information that we might think is relevant in providing greater awareness on factors that contribute to the cost of prescription drugs in our state. The key is this report cannot disclose information that is attributable to any particular drug manufacturer, wholesale drug distributor, or pharmacy benefit manager. So there are some very real limitations in terms of what we can actually publicly report. Next slide. So the focus of our first annual report is on really describing the entities in the pharmaceutical supply chain, their roles, and the financial transactions that occur within that supply chain using both MHDO prescription drug claims data that I talked about earlier, as well as the drug pricing component data that we're getting from these reporting entities. I do want to point out that we were asked to present, I want to say it was late January, before the Pharmacy Accountability Board, and I hope I'm getting their name correct. And I do think that that board will help us, along with this committee, my board, and others, refine what we can, what we can report, what we will include in future reports. Next slide. So as of December 31st, so by the end of last year, we had 337 manufacturers 182 wholesale drug distributors, and 32 pharmacy benefit managers register with MHDO. Now, that is another requirement in the law. They have to register with us. And so here are the statistics around the entities and the numbers that have registered. Next slide. So in this first year, we received 65 notifications, or we received notifications from 65 manufacturers for 192 drug products. And of these, 13 fell into the category for brand name drug price increases, 56 fell into the generic drug trigger, and 123 for the newly introduced drugs. Next slide. So based on the language in Chapter 570, MHDO limits what we ask from the manufacturers for pricing component data to only be for those NDCs that met one of the triggers that required them to notify MHDO. So in the first year, we notified 14 manufacturers requesting data for a total of 35 NDCs. And then you'll see how those NDCs, and when I refer to NDCs, I'm referring to a drug product. And you'll see that 0 fell into the category for brand name drug price increases, 6 fell into the category for generic, and 29 for newly introduced drugs. Next slide. MHDO requested pricing component data for 218 drug products from wholesale distributors and pharmacy benefit managers. We don't have the same limitation in the rule to collect data from wholesale drug distributors and pharmacy benefit managers because they don't, right? They don't set wholesale acquisition costs. They don't have a requirement to report to us if one of their drugs hits a trigger. So we asked for 218 NDCs from these folks, and those NDCs included 35 for which data was requested from the manufacturers. And then you'll see how those drugs broke out into the triggers. And then we've talked about drug product families. 170 of the 218 drugs that we were asking for fell into the drug product family. And again, the drug product family is a group of drug products that share the same generic name and dosage form. Next slide. Okay, so I've sort of set the table, and now I'm going to turn it over to Jim, who is going to talk through the key findings and walk you through an example of the interactions and financial transactions within the supply chain.
Thank you, Karen Lee. Good morning, everyone. As you review the report in full, you'll see that there's quite a bit of information. Some of it is more complex than you might like as you read through it. The subject matter is definitely complicated, and as we work through the data with the limitations of not being able to share drug-specific information or anything attributed to any one reporting entity, we had to be creative in how we displayed information and provided as much aggregate statistical information as we could in trying to still convey meaningful and useful information. Some of the key findings that came out of the report, the very first one being that generic drug pricing seems to increase at a higher percentage rate than branded drugs. And this is consistent with some of the reports that have come out from other states to date, namely in California and recently in Vermont, where folks that are hitting these triggers and reporting typically we're seeing more generic manufacturers than brand manufacturers, and that the percentage rates of increase are higher. That's typically because generic drugs are priced at a much lower basis starting point, much lower WAC than branded drugs. So as they make increases, those percentages are higher. One of the benefits of collecting drug family information in the state of Maine, which is different from the other states, is that we are able to also look at the brand drug products for those generics that have hit triggers and analyze, what is the overall impact? If generics are going up considerably higher at a higher rate than branded drug products, then, should we be looking at potentially switching back to brand? But by going through this analysis, we were able to identify that not only are generics still valuable, but the basis point for brand is so much higher that just a small incremental increase from a brand manufacturer winds up with the same discount, basically, between the brand and generic product. So in the report, the specific details are included, but we actually see from the beginning of 2019 to the end of 2019 that generic drugs are slightly cheaper, even though they've increased at a higher percentage increase and sometimes hit the triggers required by the law. So the next real key finding is that there is definitely additional benefit to be had by additional conversion to generic products where they're available. Certainly, we confirmed that the pharmaceutical supply chain is a complex place. There are not only a number of players that you would see in any typical supply chain, but there are transactional elements that occur throughout the supply chain that are triggered by contract events, not so much the movement of product. And so we'll kind of see an illustration of that a little later in this deck, but it's certainly not as linear as you might expect, just moving one product through a grocery store, for instance. Another key finding that we found, and this initial slide is kind of above industry, it's across the industry, it's not specific to the data that we're looking at that's been collected in 2019, but one of the things that we found is that the price point that's used by pharmacies to set contract pricing, which is called the average wholesale price, varies quite a bit. And this was kind of something that popped out as we were going through our analysis. And we could see quite a bit of variability in how much the end payers wound up paying for a drug, more based on the variance of average wholesale price than the variance of WAC in some instances. So something that we'll probably try and dig into further. Next slide, please. As we move forward, we're now going from kind of the industry findings to looking specifically at the indices collected in this first year. We don't want to overstate the information that we're finding and suggest that it applies all the way across the industry. But for those indices that we did review, we found that PBMs on average retained payments above what they paid pharmacies of about 11%. And so that's either in the form of administrative fees paid by payers or the form of spread, which is where a PBM contracts with a pharmacy on behalf of a payer at one price point and then contracts with the payer itself at using a different list price and winds up receiving more from the payer than what they pass through to the pharmacy, and they retain the difference. On average, in addition to spread pricing, PBMs received rebates from manufacturers that were around 14% of the average WAC amount for a drug during the year. And of this amount, about just under 80% was passed through to the payers themselves, and the rest is retained by the PBMs. The average amount that was paid by commercial payers after rebates for a given drug was around 77% of WAC. And so this sometimes is what you hear from manufacturers when they're kind of leaning back against the idea of transparency, especially around the WAC price point. And a lot of times what they'll say is, WAC is a good basis, but it's not actually how much the manufacturer is making. And so this kind of illustrates that only about 77% of the total WAC price is paid by the payer, including the consumer. And finally, the consumer share after rebates are applied for the data set that we looked at was about 27% of the total paid amount. Next slide, please. In addition to just those raw statistics, we wanted to collect, and part of the rule is collecting the factors that contribute to the cost of prescription drugs. Unfortunately, we had a very limited data set from manufacturers, as Karen Lee indicated in this first year. So what we did was look at other states that have similar legislation and have already published some of this information. And we pulled out the most common factors that were listed by manufacturers and why they're increasing the costs. These factors would have been reported based on triggering events. In the state of California, those triggers are price increases of 16% over the previous, including the current increase in the previous 2 years. And I believe in the state of Vermont, it's 20% in the previous calendar year. And those most common rationale were changes in market dynamics or conditions, which could also be probably interpreted as changes in pricing by other manufacturers within the same drug product families. The clinical value of the product, cost of improvements to manufacturing and increased operating costs, ongoing research and development, and finally, costs of increased rebates in the supply chain to ensure product availability. And we've talked a little bit about that already with the PBM rebates, but it's definitely a factor in getting branded drugs especially placed on product formularies as they use rebates in that negotiation. So that is something that we've seen in several reports. Next slide. Beyond the key findings, we wanted to just quickly walk through the supply chain itself and introduce the players. And then we could talk a little bit about some of those transaction-based events that happen. The key players are many that are the reporting entities, manufacturers, and manufacturers were qualifying as those that actually produce or repackage drug products and set the WAC price. There are also contract manufacturers and compounding manufacturers that are in the marketplace, but that's not included in this data population because they do not set a WAC value, and so we can't do apples to apples comparisons. Wholesale drug distributors, these entities typically buy very large quantities of drug products. They store them in regional distribution centers, and they sit in inventory with the wholesaler until they're needed by the end pharmacies. And that's a very actually important component of the supply chain is the time variable. The time between when a wholesaler buys a drug and when they actually sell it to a pharmacy many times involves a change of value in that product. So they may buy a product at the beginning of the year for $100, have the inventory, and in the middle of the year have that inventory increase in value because the manufacturer increases the WAC price, and so their asset becomes more valuable. That allows them to actually sell these products below WAC at the time they sell them later down the line, but still make a profit. So it can be a little confusing when you see some of the numbers. Next slide, please. Pharmacies, obviously, we're all familiar with pharmacies. They're the entities that fill our prescriptions. PBMs are third-party administrators that sit between the payers and the pharmacies, and they will negotiate on behalf of the pharmacies to set pricing with they'll negotiate on behalf of the payers to set pricing with the pharmacies. They also negotiate on behalf of the payers with manufacturers to set rebates and incentives to use the various products and to set those products on preferred tiers so that they're actually used by consumers more frequently. And finally, commercial payers, health plans and insurance companies that contract with the pharmacies through the PBMs. Next slide, please. And this is our final slide, but it kind of shows those trigger-based transactions that happen throughout. And this is just for dispensing a single NDC. So you can imagine picking up just a 30-count bottle of, Lipitor at a pharmacy. This would be exactly what we'd see. These numbers are actually the average values across all the drugs that we analyzed for 2019. And so at the very first step here, a manufacturer will sell the product to a wholesaler at WAC. And so that's just under $2,000 was our average. This is really the last time we see WAC used as the price point, but it's often used as a basis moving forward. So down the line, a couple months may pass, the wholesaler will then sell the product to the pharmacy, and you can see that it's quite a discount from WAC, at just under $1,500. When the wholesaler sells the product to the pharmacy, it also triggers a component in the supply chain where the manufacturer will then rebate the wholesaler for selling the product. So you can see that they pick back up $500. At the same time, the wholesaler may also rebate pharmacies, and it's complicated because it may not be the end pharmacy that actually gets the rebate, but it could be a corporate entity above the actual pharmacy. And so that's a different trigger. It's a different flow of cash. So $120 on average. When we actually go to fill our Lipitor, as a consumer with approximately 27% of the value, we wind up paying $441 out of pocket. The PBM winds up paying the pharmacy $1,280. and the payer is reimbursing the PBM based on the contract terms. So these are all happening kind of all at the same time that the fill is actually happening. We're actually picking up our prescription. If we look at the value there between what the consumer and the PBM pays the pharmacy, we're looking at roughly $1,700. And if you look back a little bit further, you can see that the pharmacy purchased the drug product for just under $1,500 and then was further rebated $120. So they're picking up $400 or $500 in their portion of the transaction. Once we've picked up our ball and gone home, it's a typical spot to think that the supply chain is done. But actually, there's a lot of reconciliation that happens over the next several weeks and can stretch actually into months, where rebates are then reconciled by the PBM, and they go back and show transactions to the manufacturer that they've actually administered the product on behalf of one of their payers, and that triggers a rebate back from the manufacturer of just under $300 on average. And then the PBM, after they receive that rebate, pass through just under 80% in the analysis that we did back to the payer of around $220. And so that's where things end. What is also significant is that the consumer's already paid, and the payer, once they receive their rebate, doesn't call us up and say, hey, we've got an extra 27% of $220 coming back to you. That goes into the payer's pocket. And so it's supposed to be used to kind of offset costs in the next year as they set their rates. But it's certainly interesting how it all works, and there's not a whole lot of visibility to consumers. So there's a lot more information in the report, but these are kind of the high-level metrics. I'm certainly happy to answer any questions you might have.
Thanks so much, Jim and Karen Lee. So are there questions from the committee? I have some, as you might expect, but are there questions from the committee? Representative Melrano.
Thanks, Madam Chair. Was just wondering if we know if all of the reporting entities are complying, and in terms of registering and the reporting requirements.
So I'm happy to report that compliance was very high. We do have a few stragglers that we're working with, and I think the real issue is not that they are refusing to report, but they're just not aware of the requirements. So I've been working with my board. As you know, the MHDO board has the authority under rule to impose financial penalties for non-compliance. And the board gave me the authorization to move forward with that if needed. And I mean, that's the last resort. Our preference is to try and work with these folks. And I am happy to say that, I think year 2 is going to be a lot better because it's new for all of us. And there's more awareness. We've connected with the right people who know the players in the different entities, the manufacturers, wholesale distributors, and PBMs. So I think it's going to be even better going forward. But I have to say, I'm very impressed for the first year that we had the compliance that we have, and especially given some of the legal actions that have taken place in other states around, data, these types of laws.
Representative Evans.
Thank you, Madam Chair. Quick question. How many PBMs are we dealing with in the state?
I think that there is a total, and if we pull that slide back up, I think we're missing 2 or 3 PBMs that have not registered, but they are doing business in the state. So I think there's a total of 35. 32. I'll confirm that. But I will say this, I think that if you look at, and Jim, check me on this, but I think that there's a handful of PBMs that, sort of control the majority of our business.
That's correct. There's 3 PBMs that are main players, and probably 3 to 6 that make up 90% of the transactions.
Representative Matheson.
Thank you.
Sorry about that. I was just curious. I've been looking at your website, which is really great information about drug classes. I wasn't sure if you are going to do some analyses on where these different drug classes land, because I see that there's, out of this listing into the 25 medications that triggered reporting, that there's, I think, 9 agents that are diabetic agents. So I was just curious where that information was going to be presented, or if it is, or if I can find it on there, that would be great. I'm curious if you're categorizing it by drug class.
That's a great idea, and I think that's the kind of question and information that we need feedback on, so we can improve the content of this type of reporting going forward. We could certainly provide you with some information on that. But yeah, no, it was not part of, Jim, correct me if I'm wrong, but we didn't put it in this particular report, but we can certainly pull that together.
No, this first report is just kind of generalized across the market.
Additional questions from the committee? Okay. So one question I have is that it seems that the way that you did this analysis is extremely powerful in being able to track the dollars through the supply chain, which is really, really important, particularly as we try to see whether folks are actually going to be complying with our PBM law that we passed, which I think goes into effect in the next data year. So this was data from 2019, and the PBM law was in effect in 2020. Do you, as you think about preparing this next report, which hopefully will not show that the PBMs are keeping both 11% spread and 20% of the rebates, because that would be illegal in the state of Maine, do you have the tools you need to be able to report to us on the compliance with our PBM law through this report next year?
So I'll just say high level, Jim and I have been talking about that. And I think Senator Sanborn, we do, especially where we've got the PBMs, and Jim, again, check me on this, are reporting at the state level, and not a broader level. So I think we can, and it's something that we will, go back and work towards as we work on our second reporting. Jim, is that fair?
Yes, we do have the data set. It's a limited data set, right? So it's a small view, a small slice of what's going through the full supply chain. But we can, for the indices that we do collect in 2020, we'll absolutely be able to see how much is coming in rebates and how much is reporting is passing through. The other thing that we'll be able to do with regard to Public Law Chapter 469 is to look at the amount that payers are paying. Some of the administrative fees that get passed along to the PBMs now have to be reported separately from medical costs. And so in cases where we don't see fluctuations in the basis price of WAC or AWP, I would be interested to see, and I anticipate seeing, that we'll see the price that the payers pay through to the PBMs dropping, but we'll have to take a closer look.
Okay. Do you need any authorization from us to track sort of a different set or a broader set of drugs in order to be able to make sure that we have a robust enough data set to ensure compliance?
So I'm just going to say, and again, Jim, jump in, but I think what we've asked for in the proposed rule to expand the reporting from manufacturers to include drugs that are on our top 25 lists are critically important, as well as, and again, Jim, check me, the drug product families.
Okay.
It is still a limited set. If you are really interested in looking at the full spectrum, we may want to request additional data, or at least aggregate data across a broader set of indices. We can't necessarily say that every rebate is getting passed through in the same way. It definitely, I know from, at least for other entities in the supply chain, rebates vary greatly from one drug family to another. But certainly it's something we could consider and maybe talk through offline if there's, or in another session, if there's some additional compliance checking that you'd like to do for the other law.
Okay.
But if I could just add, I do think, and again, Jim, jump in, but I do think having the access to the top 25 and top most utilized, that, we could shoot for perfection. But I think there's some challenges with that. And so I think if we do have access to what is most utilized and the most costly, hopefully that gives us a good representative sample. To Jim's point, it's still a sample, but directionally, it will, I think, answer, hopefully,
Sure,
the broader question.
It'll definitely be a good enough sample size that you could identify that there may be a problem and be able to dig in further if necessary.
Okay. Representative Tepler.
Thank you, Madam Chair. And I'm sorry I missed a couple minutes of the meeting, had to step out, but if no one has asked this question yet, I'd like to get a sense of whether or not this data provides us with any indication about profit margins at various points in the supply chain. One of the issues that we've encountered in talking with either manufacturers or PBMs or wholesalers about drug supply and cost is that they point fingers at each other as responsible for increases in costs. And so it would be helpful if we were gathering the right information to get a sense of where the bumps in that supply chain are as well.
I do feel like you do have the data that it provides a lot of, if not exact profit margin, at least directional margin. There are some areas where in the report kind of explains this in more detail. For wholesalers, for example, we're not able to track exactly what the profit margin is because of some of the time dynamics where they may buy a product several months before they sell it, and how much they make in margin is not really something we can track. But directionally speaking, yes, we definitely know at each point during the supply chain how much things are being purchased for, how much is being rebated back in aggregate. And so we have that kind of broken out. There's a grid within the report that's fairly complex, but with a little time, you can see at each point where the income comes into each reporting entity and where it comes from. So you can really kind of walk through the whole transaction.
So my other question goes to the sort of bold faced words that you put on one of the first slides, which was that you can't report any particular drug and can't tell us about any particular PBM or any particular manufacturer that might have had a price increase. And then I recall in reading the executive summary of the report that you actually highlighted one generic drug that went up 400 and some odd % or something like that, but you couldn't tell us which one. And so my question to both of you is, should we be considering a broader change to our transparency laws in order to provide you with the tools to give us a report that can give us a lot more information about which drugs are going up in an unsupportable way?
So Jim can speak more to this, but I would say the answer is, if you want that specific information, then the law needs to be changed. And that's not inconsistent with, for example, the state of California. They are reporting on a publicly accessible website the names of the drugs. And again, Jim, correct me if I'm wrong, but the names of the drugs and the increases that are occurring. And if nothing else, I mean, now we could link to that site, or we could go pull information down off that publicly accessible website. But if we want to focus on, again, the top 20, what's going on in our market, it would be great to be able to report, that same kind of information within our own requirements. Jim, do you want to add to that?
Sure. No, I absolutely agree that the more that you can, that we have the ability to specify a drug, or, if you specify an NDC, anybody can figure out who the manufacturer is. So I don't think that there's a lot of controversy there. I think where you could run into legal challenges are where you get into the concepts of revealing contract details. But I think some of the language that's been talked around is being able to provide information at a wholesaler or PBM level without providing statistics that are so specific around what rebate percentages are at a PBM drug level. As long as we don't breach that, I don't think you'll wind up with much in the way of a challenge. And so from that perspective, there's not a reason not to open it up a little more. I think we could certainly do aggregate rebates across the drug family and say, these are the PBMs that we have reporting from. And that gives all the PBMs protection. We have no idea, the general public doesn't have any idea what the specific contract detail might be.
But it gives you the information that is much more actionable than what we're able to present right now.
Okay. And then I guess on that same topic, is the reporting data that we have now adequate, that if we found in your report next year that the PBMs are not complying, or some of the PBMs are not complying with LD 1504, that we would be able to unmask the data and take action on it in some way? So that's part of my concern as well.
The way I read the statute, and I'll go back and confirm this, but I believe, Senator, we could give Superintendent Chapa the information if he requested.
Okay, thank you. Excellent. Are there any additional questions from the committee for Ms. Harrington or Mr. Jones? Yeah, Representative Morris, go ahead.
Yes, thank you, Madam Chair. I just had a quick question for Mr. Jones. I apologize if this isn't any communication we've received. I just wanted a little bit on your background and on your company and that sort of thing.
Oh, sure. So I work for a firm in California. The firm's been in business for about 17 years. A lot of what we do is technology consulting and software development, and we have quite a few clients in the healthcare and pharmaceutical space. In the past, we've helped develop pricing and rebate and inventory systems for wholesalers, and various systems that kind of monitor contract details for various manufacturers. So we have a lot of in-depth knowledge of the data and how it works and how it moves through the various systems, and which data is easy to pull together and which data you might ask for is almost impossible to gather. And so initially, I started doing some consulting work in California as they set up their first transparency law, and just kind of based on their law, helped them to understand the various data levels and how best to collect the information, and then have continued to do consulting in this area since.
Thank you.
Are there any additional questions for Ms. Harrington or Mr. Jones? All right. Seeing none, we thank you so much. And I think we'll be in touch with regard to additional language that we might need to work on together.
Thank you for having us.
Thank you.
Yep. Thanks. Okay. So next up, we do have a series of work sessions, but I wanted to I think here we've been going for an hour. I think it may make sense to take just a 5-minute break to give folks a chance to do anything they might need to do in that 5 minutes. And we'll be back at 11:05. Okay, if members of the committee are present, if you could turn on your videos so that I know that you're around, we can start back up. Great. We'll wait for a few more faces to arrive. And we have a couple of members, I think, who have joined since we did our introduction. So I will invite Representative Connor to introduce himself.
Thank you, Madam Chair. Good morning still. Yeah, my name is John Connor. I represent House District 58, which is part of Lewiston.
And Senator, I'll get it right one of these times. Senator Brenner, go ahead.
Good morning, Madam Chair. I'm Stacy Brenner. I represent Senate District 30, which is all of Gorham, most of Scarborough, and part of Buxton. Thank you.
Great. So here's how I'd like to proceed this morning. I would like to start with LD 274, and then we'll move on to LD 172. Is that the right number? Yeah. Then we will pick up LD 295 and then LD 1, and then we'll do our budget discussion. So that's my plan for today. Lunch is going to intercede there at some point. But I don't know when because I don't know how much we will have to discuss on each one. So we'll play it by ear as we go along. All right. So without further ado, let's pull up LD 274 off of our table for a work session, which we had tabled last Tuesday. And I want to open it up for committee discussion. I think Ms. McCarthy-Reed had already presented her bill analysis. Can you just read the title for us, Colleen? Because I don't have it right in front of me.
Oh, sure. LD 274 is resolved directing the MHDO to determine the best methods and definitions to use in collecting data to better understand racial and ethnic disparities in the provision of healthcare in Maine. So this was the bill that directed them to develop some best practices and definitions and report back to the committee, and then it would give the committee the authority to report out legislation in the next session.
Great. Are there comments from members of the committee? Okay, seeing none, are we ready for a motion? Representative Morris.
I believe we had some questions for Ms. Harrington.
Okay.
I know Representative Quinn had some questions for Ms. Harrington, I think, from the other day.
Okay. Well, Ms. Harrington is still with us, so we can certainly have her join the meeting. And it looks like Christian's doing that already. And so she'll be here momentarily, and I'd be happy to have you ask her questions. Representative Quint, go ahead.
Thank you. Hi, Ms. Harrington. I just needed to find out, I was a little concerned with just going with race and ethnicity in this. And so I was wondering if you're bringing in any of the cultural aspects or the social aspects, because so much of that has to do with what the outcomes would be. And I think we could get a skewed view if we're just going on the racial side. I wasn't sure what sort of questioning you would be asking. I understand the reason for the bill. I'm not saying I have a problem with the bill. It's just the wording and not getting enough information to get a true evaluation going forward.
So the way I understand the resolve is that, and what we've been talking about since the draft came out, is how would we do this environmental scan? And what would be the purpose of it, and what are we trying to accomplish in this scan? And I think what's become really clear to me, as I mentioned in my testimony, MHDO does collect race and ethnicity data from hospitals for all of the inpatient, outpatient, ED, for all of the encounters that they report on. They are providing information around race and ethnicity. The payers are now required to provide data on race and ethnicity in our claims data. The issue is there's no, as far as I can tell, there's no standardized way that people are asking for that information and therefore what you're getting back is not standardized. So there's all different sources. The CDC has a code list for race and 38 and I think it gets into, Representative Quinn, some of what you're talking about around culture. Their code list is 38 pages long. And it gets into real specificity. And the CDC, right, given the work that they do, they want that granular level of information. But then if you look at other code lists, like the Department of Health and Human Services at the federal level was required under the Affordable Care Act to create a standard around race and ethnicity, that is very much drilled down into a much smaller set of questions that are being asked. And then if you look at, I just took my mom a couple of weeks ago to get her first shot for COVID-19 vaccine. And when I filled out the form for her, it asked race and ethnicity. And the questions were white, yes or no, Hispanic, yes or no. And that was what was collected for race and ethnicity. And so I think what we would like to do as if this is passed is to really drill into what is the need for identifying race, what are the use cases, what are the federal reporting requirements, and how do we come up with a strategy where all of us, whether it be MHDO, DHHS, the CDC, Health InfoNet, all of us that are asking for this kind of information are all pushing and working in the same direction so that there is a standard, so that perhaps what's being asked is uniform and what we are all receiving is uniform. I think we'll get a better set of data. And so I don't know, Representative Quinn, if that directly answers your question, but I think we want to look at everything as we drill down into this. And I think the language is broad enough to let us do that. And we need to do it with partners. I mean, this is not just MHDO doing this in a bubble. We need to be working with people that work with this data all day long. They understand it, they collect it. And so, I know there are a number of parties out there. And I do want to just say quickly, our data vendor, Human Service Research Institute, they're not only our data vendor, but they also do a huge amount of analysis and research. And they are very much, I was just talking with their CEO the other day, they are very committed to this issue and they will help us. They have created an internal team of about 16 people to focus on this topic and help us really drive that environmental scan. So I feel like we're going to be talking with the right people and the language is broad enough to help us really we can kind of go in any direction. And I think our goal is to be as specific as we can for once and for all to try and figure out, now is the time. Everybody wants this information. But when you ask them, well, what specifically do you want? They're not really sure. So that's what we got to figure out. So sorry, that's so long-winded. I've had way too much coffee and I will stop.
Can I just clarify one thing real quick?
Yes, go ahead, Representative Quinn.
Okay, thank you. That does help me out because really what I was looking for is not just outside looking in, but the community input coming from the community themselves. And I use the example of the Somali community, that you actually have people within that community stating what's going on in their families, in the community, not just having it be a racial bill. Because if we're not identifying and addressing these other things, and if we're addressing healthcare moving forward, if there's no standard, we need to make sure that we're going with specific areas and not just saying it's because of someone's race or ethnicity. So I'm much more comfortable with that. My concern is just leaving it without knowing for sure that would be addressed. If information came back next year and then everything was just decided on that and someone says, oh, well, we need to do this because of this, and you're missing out on what the bigger picture is, because it's definitely a much bigger picture than just the color of skin. And that was the point that I was really wanting to have clarified for me, because I was uncomfortable with having it be just that. So thank you very much.
Thank you, Representative Quinn. Representative Connor.
Thank you, Madam Chair. I've got a three-part question, if you'll permit me.
Sure.
Thank you very much. So, Ms. Harrington, you had mentioned when you went and got the COVID shot. So, in your information gathering, is there an opt-out for the folks that are taking the surveys or the questioning?
So let me just be really clear. That was for my mom for the COVID shot. I'm not in that age category yet, although I feel like I might.
No.
But anyways, so I don't recall that there was an opt-out, but I think you could have left it blank if you didn't want to answer it. And I don't think that would have prohibited us from moving forward with getting the vaccine.
I'm speaking specifically for more of what data you guys collect. Is there an opt-out?
Oh, okay. So yes, for the data that MHDO collects, there is in the code sets, there is a value that is either A, unknown, or you just leave it, those submitting the data, if they don't get that information from the patient or from the member, they just leave it blank.
And so do you have a rough estimate of what that percentage is of folks that just opt not to reply?
Yes. So we actually been looking at this in our hospital data, and I don't have the exact numbers in front of me, but I can tell you it's very small in the hospital data. We have very small blanks and we have very low numbers of unknowns. So it's pretty good in that data set in terms of information being filled in. In our claims data, we just started that requirement up, and it has not yet, we haven't received the data yet. It will begin with the submission of the January 2021 data, which is not until the end of, it was the end of February. So we'll be getting it, we should be getting it any day now, and we'll start to look at that.
Okay, thank you. That's all I had, Madam Chair. Thank you.
Thank you, Representative Connor. Representative Tepler.
Thank you, Madam Chair. I want to distinguish between the reporting entities, which are practices and insurers and hospitals and individuals. I would like to make sure that reporting entities are attempting to collect the data, but individuals still have the choice, the personal choice to report or not to report the data. So that's a distinction that's kind of important to understand. And MHDO doesn't deal with the individuals. They only deal with the reporting entities.
Mm-hmm. And if I could just respond to that, Representative Tepler, that is a critical part of the environmental scan. It's one thing for MHDO to pass a rule that says here's the structure to provide this data. If the data, if it's not being asked for, then we're going to get to Representative Connor's point, we're going to get all blanks. Mm-hmm. It's not that people aren't filling it out, or it's just that they're not being asked. And so therefore we don't know. If somebody were, and the difference in the data world between leaving something blank, not filling something in, and indicating unknown is somebody was asked the question and they chose not to respond. And therefore it is unknown. That is different in the data world than a blank, which when you don't submit anything in a field, the understanding is it wasn't collected or asked for. So we will be doing an analysis of, in the payer data, how much of that data is blank versus unknowns.
Okay. Is there further discussion on LD 274, or are we ready for a motion? Okay. So we had discussed also adding an emergency clause to this bill so that the work that Ms. Harrington described could be done a bit more quickly. Just to be frank, I don't want to add an emergency clause if there's opposition to the bill. So I just wanted to check in with Representative Quinn, Representative Connor, whether they had opposition to the language of the bill now that we've had a chance to talk about it for a couple of days. Representative Quint?
I'm more comfortable than what I initially was. I'm glad that we're able to get the fuller picture, and I appreciate that it will be coming back. And if that's left out, then I will definitely, have something to say at that point. But I am okay with it as is. So thank
Okay.
you. Thank you for taking
Great.
my concerns.
Absolutely. So with that, I guess just to expedite things, I'll make a motion ought to pass as amended with an emergency clause added to the bill. Is there a second for the motion? Senator Brenner has seconded the motion. Is there any further discussion on the pending motion? All right, seeing none, I'll ask the clerk to call the roll. Whoops.
Right. Representative Quint?
Yes.
Representative Quint ought to pass as amended. Representative Connor?
Yes.
Representative Connor ought to pass as amended. Representative Blyer?
Yes.
Representative Blyer ought to pass as amended. Representative Morris?
Yes.
Representative Morris ought to pass as amended. Representative Matheson?
Yes.
Representative Matheson ought to pass as amended. Representative Evans?
Yes.
Representative Evans ought to pass as amended. Representative Arford?
Yes.
Representative Arford ought to pass as amended. Representative Melorano?
Yes.
Representative Melorano ought to pass as amended. Representative Brooks?
Yes.
Representative Brooks ought to pass as amended. Senator Stewart? Absent. Senator Brenner?
Yes.
Senator Brenner ought to pass as amended. Representative Tepler?
Yes.
Representative Tepler ought to pass as amended. Senator Sanborn?
Yes.
Senator Sanborn ought to pass as amended.
Great. Okay. So the next bill that we are going to pick up off of our table is LD 172, which was tabled a week or so ago. And Colleen, can you remind us what this bill is about?
Sure. This is the bill that Representative Craven introduced. It's an act to improve prescription information access. The bill as drafted would require a QR code to be placed on prescription drug labels to help assist those folks who are visually impaired. It would also direct the Maine Board of Pharmacy to adopt some rules. And just to refresh your memory about the history, this was a piece of legislation that was considered in the 129th legislature. And as a result of that legislation, the committee had asked the Maine Board of Pharmacy to do some reporting and reaching out to their licensees to recommend best practices for how to assist those who are visually impaired. And while the report was delayed by the Maine Board of Pharmacy, they did reach out at the beginning of February to all their licensees, and we received copies of that communication at the during one of our previous work sessions. I did forward some follow-up information from the Maine Board of Pharmacy that we received today by email, just in follow-up questions that were raised at the last work session, just describing some of the efforts that pharmacies can use now and some of the practices they can use now and do use in certain circumstances to assist folks who are visually impaired.
Representative Tepler.
Thank you, Madam Chair, and thank you, Colleen, for your help in reminding us about this bill. I had a conversation last night with the Honorable Roger Fuller, who is seriously visually impaired, about the problems that he has had that brought this bill forward the first time and the second time. And you should know that Mr. Fuller has visited 4 different pharmacies, the one that is within walking distance of his home and 3 others that he had to get a ride to ask about accommodations for the eye drops that he takes. He takes, I believe it's about a dozen eye drops, and it is very difficult for him as a visually impaired person to distinguish between the types of drops. So the 4 pharmacies that he visited, none of them were able to offer him any further accommodation than a large printed version of the medical information, which doesn't help him distinguish between the bottles. So we have a problem with to some extent, it appears a gap between the pharmacists who have a duty to attempt to accommodate their clients and their employers who may not have that duty. And I guess what I would like to see us do is convert this bill to a resolve that asks the Board of Pharmacy to do a scan of the situation in Maine. And the situation in Maine in regards to what kinds of accommodations are available, actually available in pharmacies in Maine, not just suggested or possible, but actually being provided, and how many of them are being provided to visually impaired clients. And also just sort of a generic scan of what could be available and how it could possibly be made available more widely in the state than it currently is. So that's my thought about this bill, and just converting it into a resolve that directs the Board of Pharmacy to do a little more work to see what's actually going on in Maine for the visually impaired, and to provide a little more information about how we can improve that situation.
Representative Connor, go ahead.
Thank you, Madam Chair. I have no problem being the idiot in the room. As the newbie, if you could explain the difference between what a resolve will do for folks like myself, I would be greatly appreciative.
Colleen, do you want to address that?
The difference between the bill itself and a resolve. Well, a resolve just generally with changing it to a resolve just is the instrument that the legislature uses to reflect sort of one-time, time-limited directions to a state agency. So the previous bill we just discussed, which was LD 274, was drafted as a resolve because that bill would direct MHDO to do a report and report back to the committee in October, and then essentially their requirement would go away. It's not a permanent ongoing requirement that they would report to the HCIFS committee annually on this topic. So what Representative Tepler, I think, is talking about is a similar language that would direct the Maine Board of Pharmacy to do some further study of this issue and report back to the committee at one particular future date. It would be a one-time directive to the Board of Pharmacy to do that. It wouldn't be something, it wouldn't be an ongoing responsibility.
Thank you. Again, I apologize. Thank you.
Not a problem. Representative Tepler, go ahead.
Sorry, clicking the button repeatedly. Thank you. And I think we could also say that it's not something that is chaptered in Maine law. So it doesn't become a permanent part of our system of law as a resolve, whereas a bill generally does. This is a directive to an agency to do something. And I did want to add that I'd like to include a report back to our committee with the ability to report out a bill afterwards. Thank you.
Representative Connor.
Thank you, Madam Chair. This is something that I would be in favor of. I'll be honest, I was not in favor of the original bill. I had some serious questions about mandating pharmacies to do such a thing. So I would definitely be in favor of a resolve and getting more, putting it on them to come back to us with something versus the opposite. So thank you.
Are there additional comments? Okay, and just Colleen, I think in terms of being specific about how what we're asking for differs from the email that we got today, I think the idea here is that we're looking for real data from licensees as to what's really happening on the ground, not just
So like,
generally what could happen.
So more of a survey of,
Yes.
of some sort, asking have you had visually impaired patients? How many do you serve? And what accommodations do you provide, or something along those lines?
Yes, exactly right.
Okay.
Yep.
Can I-
Perfect.
Okay.
Senator Brenner, go ahead.
Colleen, can I just ask for potentially one piece of information in the future, if it's possible? And I'm not sure, but I'll ask it now anyway. I'm just wondering how this falls under the purview of the Americans with Disabilities Act, and whether or not it's a requirement for pharmacies and pharmaceutical products to arrive to a consumer with more ability for the consumer to understand what's going on when they have a visual impairment.
I've looked into this a little bit, and this is really probably a generalization, and I'd have to look at more specifically about if there are any rules about prescription drugs generally, but the Americans with Disabilities Act, as I understand it, would require employers like a pharmacist or a pharmacy to provide reasonable accommodations to folks that have a disability, including a visual impairment. And it may very well be that providing some of the description that Representative Tepler talked about, like access to the label in large print, might be seen as something that would be satisfactory or reasonable as a legal requirement. But I think what Representative Tepler seems to be getting at is talking about sort of maybe going beyond that to serve some of the specific needs of the client. So I think she may be seeking, there may be a distinction between a reasonable accommodation that meets the legal requirement under the ADA and something that really assists or is sort of directed to specifically help an individual with a visual impairment. So that's how I would describe it. Yeah.
Great, thank you.
Mm-hmm.
Okay, are we ready for a motion on this bill? I think the absence of hands suggests that we are, although that's a little odd. Representative Tepler, go ahead.
Thank you, Madam Chair. I'd like to move ought to pass as amended to a resolve.
As we described.
As described.
Great.
And would you, one question just about the timing, would you want it to come back next session for this legislature to be able to deal with it? Okay. Just check.
Yes, I think a report date of January 15th would be reasonable.
Yep. Great.
Yep. That's
Thank
great.
you.
Okay. Do we have a second for the motion?
I'll second.
Representative Connor seconds. Great. And Representative Brooks, go ahead. Was that just a second?
No, I was making sure that the amendment includes that ability to report out, to have a bill.
Yeah. I think we don't need that language because any report triggers the ability to report out a bill, but we'll put it in there for the absence of doubt. Okay. Seeing no further discussion, I'll ask the clerk to call the roll.
Representative Quinn.
Yes.
Representative Quinn ought to pass as amended. Representative Connor.
Yes.
Representative Connor ought to pass as amended. Representative Blyer. Can you unmute your mic?
Yes.
Representative Blyer ought to pass as amended. Representative Morris.
Yes.
Representative Morris ought to pass as amended. Representative Matheson.
Yes.
Representative Matheson ought to pass as amended. Representative Evans.
Yeah.
Representative Evans ought to pass as amended. Representative Arford.
Yes.
Representative Arford ought to pass as amended. Representative Melorano.
Yes.
Representative Melorano ought to pass as amended. Representative Brooks.
Yes.
Representative Brooks ought to pass as amended. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner ought to pass as amended. Representative Tepler.
Yes.
Representative Tepler ought to pass as amended. Senator Sanborn.
Yes.
Senator Sanborn ought to pass as amended.
Great. So the next bill that we're going to take up is LD 295, which is one we have not yet worked. So I'm going to start with having Colleen present her bill analysis for us.
Okay. So here we go. You have received this previously, but as Senator Sanborn said, I think the day that we intended to work this, we ended up tabling it. So I don't think we ever actually got to any discussion of it. And I'll just note that you continually have been getting emails from folks on both sides of this issue right up until it looks like just a few minutes ago. I have not had a chance to review some of the additional information that's been coming in over the last day or so, but I do know you're receiving that in your email, as I said, from additional testimony from folks and information from folks on both sides of this issue. But LD 295, as drafted, is an act to repeal restrictions that prohibit certain advanced practice registered nurses from providing essential healthcare services. The bill eliminates a provision in law requiring that a certified nurse practitioner who qualifies as an advanced practice registered nurse must practice for at least 24 months under the supervision of a physician or supervising nurse practitioner, or be employed by a clinic or hospital that has a medical director who is a licensed physician. The bill also removes a requirement in statute that would require a certified nurse practitioner to complete 24 months of supervised practice before they can qualify as a supervising nurse practitioner. I did want to mention that this provision has been suspended by executive order of the governor during the declared state of civil emergency. As part of the executive order of the governor, the restrictions on supervised practice for certified nurse practitioners, as well as the requirements related to physician assistants for collaborative practice agreements, which we'll talk about, have been suspended during and are currently suspended during the state of emergency. So this is the provision in current law that defines what advanced practice registered nursing is. And you'll see highlighted in yellow, that's the language that's proposed to be repealed by LD 295. So under current statute, as I mentioned, a certified nurse practitioner who qualifies as an advanced practice registered nurse must practice for at least 24 months. So that, and the statute also requires that the certified nurse practitioner submit written evidence to the board to comply. The board also has some rulemaking authority related to these provisions. So this is the language that the bill would repeal, and then there's a corresponding provision, as I mentioned, related to the qualifications of someone to become a supervising nurse practitioner that are also proposed to be repealed by the bill. And this is just this chart, and I know folks have, think I might have minimized the, showing it to you, minimized the amount of postgraduate training and the hours that physicians, for instance, receive as part of their postgraduate training. But this is just really trying to show you the minimum requirements, and then to the extent to which there are additional requirements in the licensing statutes that apply to certified nurse practitioners compared to physician assistants and physicians, all of whom have some ability after meeting these standards to sort of independently practice. And so some of the issues that were raised at the public hearing related to the comparison between certified nurse practitioners, physicians, and physician assistants. So certified nurse practitioners and physician assistants at a minimum have master's level requirements. There are doctorate level programs available for both of these providers. Physicians are required to complete both 4 years of medical school, and then their residency is a period of 3 years minimum, up to, more years can be required depending on the specialty of the physician. And during that period of residency, their practice is supervised. They're all required to take national exams and certification in their area. But then this last category was really trying to show you in the specific licensing chapters if there are any additional requirements as part of or conditions of their license to receive, to have that ability to practice, which I'm calling independently or without supervision. So this is just the last bullet here. The last box here shows you that under current law, certified nurse practitioners must complete 24 months of supervision. With regard to physician assistants, there was a recent change in legislation in the last legislature, removing the supervisory requirements and replacing those with requirements related to collaborative agreements or practice agreements, depending on the number of hours that physician assistants have practiced. And I think I saw a hand, because I get a little
Representative
box,
Tepler.
so there might be a hand. So I'm happy to get interrupted as I go through.
Representative Tepler, go ahead.
Thank you, Madam Chair, and thank you, Colleen. There's one piece here that I think is missing, and I just want to point it out or have it fleshed out a little bit. So in order to become a certified nurse practitioner, I believe you have to be a licensed RN. And in order to be a licensed RN, there are certain clinical requirements. So I guess I need to know about those clinical requirements. And I believe that physician's assistants don't have any clinical requirements before they become physician's assistants or enter a physician assistant program. So if we could add the information that reflects that to this chart, I think that would be helpful.
Sure. I mean, I'm happy to do that. I was trying to just try to be as succinct as possible and get it onto one slide, knowing that I'd have to explain sort of the nuances. But you're absolutely right that in order to qualify to be a certified nurse practitioner, someone must be and have gone through the licensing requirements to become a registered nurse and follow both, those educational requirements for, as part of their receiving their RN. It would require, as part of their education, there's clinical practice associated with that. With physician assistants, they enter, a similar master's level program. So I can definitely get more detailed as if that would be helpful. And clearly sort of the description of the, education and training of physicians is also minimized too here. But I was just trying to show you it very quickly for purposes of the bill analysis.
So
thanks, Colleen. Go ahead, Representative Tepler.
Thank you. I guess the only issue is whether or not, and this includes physicians, they're required to have any clinical experience before they enter these programs.
Before entering medical school, you mean?
Yes.
Well, there are minimum sort of education requirements for all of them before they are accepted. All of the educational programs have certain course requirements and other types of things. I don't believe that there are any specific clinical practice requirements as part of your college level classes that you would take for either of those. But I can certainly describe more, do another chart that's very specific and pull out all of the individual elements of licensing required.
Thank you.
Mm-hmm.
Representative Connor.
Thank you, Madam Chair. Colleen, on the first column there under certified nurse practitioners, the postgraduate training, the 2 to 2.5 years, can that coincide with the 24 months of supervision? Does it normally, or is it completely separate? I'm curious because I honestly do not know.
My understanding is that's separate. So
Okay.
They complete their master's level training and then they have to complete the 24 months of supervision sort of on the job, if you will, under the supervision of either a physician or a supervising nurse practitioner.
Okay, and then under the physician column, the 3 years residency, could we almost equate that to supervision? I mean, they're not technically practicing on their own, correct? If they're in residency, could we look at that as flowing down to the bottom column as they're being supervised for those 3 years?
I think, yeah, you definitely can in terms of like they're being supervised. What I was trying to show in the bottom column was really if there was any requirement in the licensing statute to become a physician, over and above, once you're licensed. And so with physicians, it's my understanding that once they've completed their residency and their 4 years of medical school and they qualify, pass their exams, they receive a license that allows them to be independent, practicing independently. And with regard to, as I understand it, certified nurse practitioners and the physician assistants, the licensing statute requires an additional 24 months of supervision in order to qualify for that particular certification as a certified nurse practitioner. And then with physician assistants, once they've completed their training, if you will, and education, then there's additional requirements related to, hours of practice related to this collaborative agreement. You need to, if you're less than 4,000 hours, you need to work under a collaborative agreement. And then if you have more than 4,000 hours of practice, you're allowed to practice independently if you have a practice agreement in place with other healthcare providers. So that's really why they're, the columns were separated. But I think you can certainly, if you're thinking about the supervision and the training of physicians versus certified nurse practitioners, you can view those similarly, I think, in terms of the supervision that they would receive from other either physicians or other nurse practitioners in the case of nurse practitioners.
Thank you. That's all I have, Madam Chair.
Thank you, Representative Connor. Representative Arford.
A few more hands, yeah.
Thank you, Madam Chair. I have two questions. The first is, in speaking with one of a nurse practitioner who was just about to graduate, who contacted me, she told me about a nurse practitioner residency program that now exists in the state of Maine. She wasn't aware of more than one, but she had applied for it and she was hoping to get accepted into it. And my question is, if she, this particular individual, or anybody else in her situation, was accepted into this nurse practitioner residency program, would that qualify for at least 1 year of supervision?
I don't believe that would under the existing statute, but I haven't looked quickly to see if you have representatives in the room from the Board of Nursing who might be able to specify that. But they did provide some information about sort of the current practice, and those are on some of the different slides. So as we go forward, I can give you some of the information that they reported back in terms of the current practice and how it might impact people, for instance, coming from out of state, folks who are licensed from out of state, as I understand it. If they want to be licensed in Maine, they have to demonstrate proof of 24 months of supervision in Maine in order to receive a Maine license. So those sorts of things are occurring now. And so I think with the residency program, if it was part of their education, it may not qualify and meet the standards of this licensing provision.
I don't
Representative
know.
Arford, do you have a second question?
The second question is the other thing I learned, and I think someone is here representing the Board of Nursing, but another thing I learned from the Board of Nursing was that in the case of a nurse practitioner, they had, after graduating from their program and applying to take the certification exam, they had a 2-year time period during which they had to pass it. And they were allowed 2 years, but they could be functioning and working as a nurse practitioner during that period of time. After 2 years, if they hadn't passed the exam, they would have to stop. And I just think that's another important piece of information to know. And my question is that true also for a physician assistant? Do they have this 2-year time period after they graduate and while they're working, during which they can pass whatever their certification exam is?
I can follow up with that to find out. I'm not sure about the physician assistant and how the licensing exams and certification exams work for that, but I can certainly follow up. And I just don't have the attendee list open. I think you do have representatives of the Board of Medicine who may be able to answer that question too as we're moving forward.
Thank you.
Mm-hmm.
Okay, Senator Brenner, go ahead.
Thank you, Madam Chair. And thank you, Colleen, for putting all this together. I would love on that first column under certified nurse practitioners, if we could make sure to reflect the prerequisite for the program, which includes a Bachelor's of Science in Nursing, which is a 4-year degree with clinical training, and also the successful completion of the NCLEX exam to pass your board successfully to be a registered nurse in advance of being accepted into the program.
Sure.
Thanks.
Okay. All right, let's let Colleen go on to the next slide.
Sure. So in response to some of the questions that the committee had asked, you did not hear or you receive any testimony at the public hearing directly from the Board of Nursing. And so at the committee's request, I reached out to their staff to see if it had been discussed and if they had any input. Particularly committee members were interested in whether or not they had any thoughts about what the impact of the removal of the supervisory requirements might be related to patient safety and quality of care. And so this slide really just directly sort of copies for you the information that I received back from the comments I received back from their executive director. She shared that they did review the bill at its one of its meeting in January. They did not take a formal position on the bill as a board, but it did not raise any concerns to them at that time about risk to patient safety or quality of care if the provisions were repealed. And then she also offered some additional comments related to the board's discussion, describing sort of what the application process is currently. As part of the application process for an initial license, the applicant's required to submit a first-time registration with a primary physician or nurse practitioner as their supervisor. And then at the end of 24 months, they're required to submit written evidence to the board that they've completed that 24 months. And the evidence that's required is a letter from the supervising physician or nurse practitioner stating that the nurse practitioner has been supervised for 24 months. The registration for a supervisory relationship is not additional training for nurse practitioners, it's supervision. The supervisor is not required to be on site. And I think committee members remember some of this discussion and when we talked about physician assistants during that legislation. The documents required during the process are to the board are the initial registration and the letter stating that they've completed the 24 months. And then on the issue about nurse practitioners practicing in other states that might apply for licensure in Maine, those nurse practitioners must provide proof that they've been supervised for 2 years or register for a supervising relationship in Maine. And as a result, the board has indicated that some nurse practitioners opt not to continue the endorsement process. And in other instances, when a nurse practitioner opts to register for a supervisory relationship, he or she may have had many more years of experience than the supervising physician or nurse practitioner in Maine, since they're coming from out of state and may have been practicing in another state as a nurse practitioner for several years. So the other issue is she also indicated that similar to how the other professional licensing boards do it, the board does rely on evidence-based research on a variety of topics, including scope and standards of practice, and this information is reviewed by the board when determining current best practices. In addition, the information is shared with those who make changes to and update the Nurse Practice Act in order to make sure that they're reflecting the current evidence-based research to make informed decisions. And on that issue, I just wanted to go back to the first slide in the current law, just to point out for you, while LD 295 does repeal this supervisory requirement, the language in paragraph C, which is here, would still require advanced practice registered nursing to mean in accordance with standards of practice for advanced practice registered nurses as specified by the board and rules, taking into consideration any national standards that may exist. And advanced practice registered nursing includes consultation with a referral to medical and other healthcare providers when required by client healthcare needs. So that standard will still remain in the statute in terms of when and if there may be a need to consult with other medical providers when required by client healthcare needs. That does remain in the statute. It's not being repealed by LD 295. The committee members were also interested in some information from the Board of Nursing as to complaints, if there have been any complaints about certified nurse practitioners during this period during which they're required to have supervision. And they did have a chance to take a look back at complaints that were filed against nurse practitioners in the last 5 years. They indicated there were 144 complaints. 14 of those were filed during the supervisory period for those nurse practitioners. They indicated of those 14, 13 were dismissed and 1 resulted in discipline. Of the remaining complaints, which are 130 complaints filed in the last 5 years against nurse practitioners after the supervisory period, 112 of those were dismissed and 18 resulted in discipline. So their information reporting back was that there didn't appear to be any evidence that new nurse practitioners in Maine are more likely to have disciplinary issues, safety issues, or quality of care issues than longer practicing nurse practitioners.
Representative Connor.
Thank you, Madam Chair. Colleen, do we know if those 144 complaints were those patient complaints against the NPs, or did that also take into account perhaps the supervisor, provider that may have had a complaint against the nurse practitioner? What I'm getting at is not everybody is fit for the job that they're trying to do, and so if a supervisor has an issue with the subordinate, if you will, for lack of a better term, and then they, through whatever discussion, they mutually decide that it's best, maybe not the best path career-wise for this individual, is that information captured, or is it just complaints by patients?
My understanding is that it could be complaints by both potentially, but I don't think that they broke down that information on, as to these complaints.
So the Board of Nursing is on the call if we wanted to ask that question of them. But I mean, I think what Colleen has said is right, that there's no breakdown here at least. So do we want to bring in the Board of Nursing now, or do we want to continue on? Colleen, have you gotten through your whole analysis?
I think I have one more slide, but after that.
Okay, let's do that first.
Okay. And then lastly, really just, you've heard a lot of talk about some of the issues in other states. You also received information sort of comparing authority for nurse practitioners in all states. You've got information from other parties about the practice authority and education requirements of physician assistants and also physicians compared to nurse practitioners. But I just sort of tried to summarize for you some of the information really quickly. I can share with you some of the full charts have been shared with you previously by email, but this was just trying to summarize for you here in terms of how other states treat nurse practitioners with regard to supervisory requirements. There are 13 states that have been identified and described as authorizing full practice with no supervisory requirements, and those are listed. 10 states, including Maine, have some sort of supervisory requirement as nurse practitioners transition to independent practice, and those are noted for you. Some are based on a time period like Maine, months or years. Others are sort of equated to the number of hours. And then there are 6 states that have also have certain hours sort of required for nurse practitioners related either to their ability to practice independently or their ability to prescribe prescription drugs. There are also still other states that are considering in their state legislatures changes to these requirements this session. And then lastly, just in terms of the fiscal information, if you do move forward, eliminating these requirements under the licensing statute may reduce registration and other fees received by the Board of Nursing. It's expected to be minor, but the fiscal information would note a potential revenue decrease to the Board of Nursing. And I'll stop there and turn off my screen so everybody can see each other, and also I see the participant. Who else is in the room?
Great. Representative Quint, go ahead.
Sorry, I was taking notes when I heard some information come up. I know that the RNs, we have to pass the NCLEX. But then I heard something with the NP exam. They have 2 years in which to take that. In other words, they're practicing as NPs without taking the exam. Did I hear that correct? Or not?
Let's invite someone from the Board of Nursing to join us. So if, not sure who it is that's here. I don't know if it's Valerie Fuller. Is that who it would be, Colleen?
Well, you could bring in
Kim Escabel.
Kim Escabel is the director of the Board of Nursing. If you'd like to hear from her,
Okay.
I think Ms. Fuller is a member of the board, and maybe the chair
Got
of the
it.
board could also hear from
Okay.
her if you wanted.
All right, so we'll bring in Ms. Escabel. And then I think we can have her clarify that piece.
Hi.
Hey, good morning. Thank you. Or I guess it's almost afternoon. Thank you for joining us.
I would really like to defer the question to our Assistant Executive Director. She actually processes all of the NP applications. It's Virginia Delormier.
Is she here with us on the call?
She's coming. I'm bringing her in now.
Great. Perfect. Okay.
Yeah. Sorry, I missed your email, Kim. I would have said that earlier. Sorry, I can't do all these things at once. Sorry.
Too many screens. All right, Ms. Delormier, if you can hear us, if you could unmute your mic and turn on your video. There she is. All right. Can you hear us?
I can hear you.
Great. We can't see you, but that's okay. Did you hear the question that Representative Quint asked, which was about, there we go. Now we can see you as well.
Yes, I did.
The question. Okay, go ahead.
Yeah, basically, there is a part of our statute that allows for an individual to, when they apply for their nurse practitioner licensure, if everything is in place except for the exam results and someone wants to hire them, we can issue a temporary authority to practice if everything is in place except for the exam results. That temporary authority allows them to stop practicing. They can't prescribe narcotics, but they can do most the other things under supervision. And then if they can do that until they fail the exam twice. If they fail the exam twice, then they can no longer do that. But there is that authority to give a temper. I don't do it very often. It's not requested very often, but there is the authority for that.
All right. Are there additional questions? I think we had a question about a residency program for nurse practitioners as well. Would you like to speak to that?
Sure, I can. If someone does enter any kind of program after graduation, they have to register a supervisory relationship. If that's part of that residency program, that would count towards it, but it's considered supervision, and they can do it only with registration of a supervising physician or NP.
Representative Bleier.
Yes, the question I had, and I don't know who to present it to, but it was about the complaints, the 100.
Representative Bleier, you muted yourself while you were talking. Can you try again?
Yes. So it's about the complaints that you had. You had one disciplinary, and I'm wondering what that result was. Are you able to share that or have that information?
This is Kim Escabel. I can speak to that. There's a number of reasons that a nurse practitioner can be disciplined. It's typically for unprofessional conduct or incompetence. There's also other things such as fraud, obtaining a license through fraud and deceit.
I can certainly provide those specific outcomes for you if you would like.
Representative Connor.
Yes, thank you, Madam Chair. I was curious to know if we have data on the number of NPs that were in the 24-month supervisory timeframe that either left the industry for self reasons, or if they left the industry because of some of these issues that came up in the past, like you're discussing for disciplinary reasons or whatnot. What do you have that data of the number that actually left within that 24-month time period?
We do not. We don't keep track of that. A nurse practitioner that has a supervisory relationship, they can change supervisors during that 2-year period. So if for some reason they just don't click, they can certainly register another supervising relationship. Or they may decide to change specialties, or they may decide to move. There's a number of reasons they would do that.
A follow-up, Madam Chair. So would that show that the 2-year supervisory period is doing what it was designed to do to catch those individuals, or is that just something completely different?
The only thing that is required from the Board of Nursing is a registration for supervision and a letter at the end stating that they have completed 24 months of supervision.
Thank you, Madam Chair. That's all I have.
Okay. Are there additional questions for our guests from the Board of Nursing? Okay, we're going to push you back to the attendee group at the moment and continue our discussion. I'd like at this point to know if folks have additional sort of questions or additional information that they need from Colleen or from someone else at this point. I don't anticipate, for the record, that we're going to finish this bill today. So this would be information that could be brought back to us for a second work session, or potentially someone in our attendee pool on the Zoom call might be able to provide it. So I want to try and get all the information requests out right now. I think Representative Bleier was the first to raise his hand.
Thank you, Madam Chair. I guess it's more of a concern, with this. So I'm leaning in favor of this bill, but having a nurse practitioner practice before the exam results are in, for me, is a little problematic. And so I'm wondering if we can incorporate that within this bill, where there has to be supervision in that period until the exams results are in. That's my concern. I just wanted to see if we could have that maybe addressed.
Okay, that we can certainly note that for our discussions going forward. I think Representative Tepler's hand was up next.
Thank you, Madam Chair. My question for Colleen is, it would be helpful to me if we also had an outline of the scope of practice for each of the professions, because it helps us to distinguish issues around adequacy of preparation. So I think that would be very helpful.
And I just want to comment on that I think we may be asking the question slightly in the wrong way with regard to that, because my understanding, and Senator Brenner can speak to this much better than I can, is that nurse practitioners' scope of practice is specifically tied to their licensing exam. And there are a lot of different licensing exams. And I think that's true with regard to medicine as well, but in a different way, if I understand it correctly. And probably in it's going to be hard for us to articulate scope of practice. So because there's so many different types of licensure and exams at the federal level, or at the national level, I guess, I don't mean the federal government, but at the national board level, under each of these professions. You could be a board certified heart surgeon, which gives you a certain scope of practice, but which would be quite different than, you know, a family nurse practitioner or a family doctor. So I worry that we're going to get way too in the weeds here in terms of the response to the question. So I'm just trying to maybe give Colleen a better
That could be,
direction.
Yeah, there are, I think there's 6 or 7 maybe for the nurse practitioners that when I was looking at the different certifications, but I can certainly try to give you as much as I can, and sort of there are general scope of practice definitions that I could give you, but again, it'll be general, and you know, realizing that there will be nuances and caveats about it, I can certainly do my best to pull something together.
And I guess,
Representative Tepler, go ahead.
yes, thank you. What I want to understand is the limitations on the scope of practice, I think is probably the focus that I at least would like to see.
Okay.
The limitations created by the scope of practice.
I think that's helpful. Representative Arford.
Yeah, quickly, 3 of the nurse practitioners that called me that I spoke with said that it would have been a more meaningful experience for them if they had been able to be supervised by another nurse practitioner, but there were none available. So they were supervised by a medical doctor. Not that that wasn't a positive experience. It just, in their mind, was not as meaningful. It was So my question is, it's my understanding that for a nurse practitioner to qualify to supervise, she has to have 10 years of medical experience and 5 years of practicing in the same specialty area that the person she's going to be supervising is. My question is there any standard in the industry of what they require of a nurse practitioner supervisor? Because personally, I think that's onerous.
Okay.
And that we might, so.
You mean any standard in other states?
Well, nationwide, if there's a standard. That of the states that do still require some form of supervision, is there a standard of what they then require of the nurse practitioners who can serve as supervisors?
Okay. Because it is laid out in our statute. So I just wanted to be clear you were asking for other states. Okay. Go ahead, Representative Arford. What were you going to say?
No, that's it. I just was trying to get a sense of if there's a nationwide standard and how our standard compares to that.
Okay. Representative Quint, I think you were next. I'm not sure why people aren't staying in the same order, so I apologize if I'm not seeing hands at the right time.
No, that's fine.
Go ahead.
I appreciate all the really good questions because I think this has potential going forward, but safety concern issues as well. I'm just wondering if someone is coming from another state, I'm not sure who can answer this question. As far as the 2 years of experience, if they're able to show that, is there a way to delete that from them having to actually do that supervision in Maine? Or if they've had 2 years of experience already in another state, are they exempt? Do you know what I mean? Are they exempt from that 2 years?
I do, and I think we actually know the answer to that question, which is that if they have to be able to show that they have 2 years of supervised experience in another state. So if they're coming from a state that didn't require supervision, they won't be able to show that, even if they practiced for 20 years. And then they could register for a supervisory relationship with the board, and they may be supervised by someone who actually has less experience than they do. And that's exactly what the Board of Nursing told us in their response. Does that make sense, Representative Quint?
It does. Can I just ask another question then? With that, does this bill have workability where amendments can be made to allow that sort of thing? But also, I had another question. I'm not sure if this is really the time to do it, so I'm sorry if it's out of order. But even with having the 2 year, I'm not as hooked on that, but still having a supervisory period. When you have new graduates, I understand that they've been RNs, but they can graduate as an RN and go straight into the NP program without ever having worked as an RN. And I know going as an RN, we have to actually pass our exam first, but I had a ton of questions, and having that supervisor, over you who can help you with that. If you're in the middle of nowhere, I've lived in both Washington County and I currently live in Aroostook County, and we have a lot of our care provided by PAs and nurse practitioners. And if we have a new grad come out there with not a lot of supervision, I do have questions about safety, and I have witnessed this myself, where a new nurse practitioner coming out may not have known as much of a subject that I myself have, going back to the experience, like someone from out of state having to work under a doctor, who may not have as much experience as they have. So those are just some of my concerns going forward, so you can see my thought process. And if anybody can speak to anything that I'm saying, I'm totally open to it. So thank you.
Thanks, Representative Quint. Representative Evans had his hand up and then lost the call, I think. So I want to go to him next.
Yeah, thank you, Madam Chair. I don't know how long I'm going to be visible or heard because I keep flashing in and out.
Okay.
I have significant concerns. And we were talking about the level of training, education. We did not include the fact that for physicians, you also have to have a degree from college before you start medical school. The clinical aspects of training is the most important aspect. The book knowledge is one thing, but the actual training, postgraduate training in different areas is what you are most reliant upon. And that's where you develop your clinical judgment. One other thing that I would like for the Board of Nursing to address is the number of master's programs that are in each state, and with 100% acceptance of every person who applies, and even here in Maine. And then the other aspect is liability as far as practicing independently. I know for a fact that case law is currently, has consistently demonstrated that physicians are held to a higher standard whenever something adverse occurs. I don't think that the nursing independent practitioners are held to that same standard. So those
Okay.
would be, I'll be concerned about.
Thanks, Representative Evans. Senator Brenner.
Thank you, Madam Chair. For the Board of Nursing, or for Colleen, as we start to talk about scope of practice, I'm gonna maybe see Representative Tepler, if perhaps we could narrow the scope of your question to talk specifically about like maybe the top 5 specialties for nurse practitioners in the state in terms of their scope of practice, so we can have clarity about the bulk of the nurse practitioners that we're speaking about. So there's 1,142 family nurse practitioners. That's the largest group. And then there's 194 adult nurse practitioners. And there's 112 family psych mental health nurse practitioners. And 142 adult psychiatric mental health nurse practitioners. And then the 5th one is adult geriatric nurse practitioner at 62. So that's a little bit of a breakdown. But what it does is it gives you the picture that your biggest class of folks that we're talking about here are family nurse practitioners. So I think if we could specifically address for me what their scope of practice is for the group, that would be helpful, because it is quite different than a physician. And as mentioned, they're also paid quite differently.
Yeah. Representative Tepler and then Representative Evans.
Thank you, Madam Chair. And I'm certainly open to Senator Brenner's comments. I think that's very reasonable. I do have a question, though, about supervision. Is there a requirement that the supervising physician, if the NP has a supervising physician, have a specialty in the same area as the NP is training for? So, for example, does it have to be a psychiatrist if you're a psychiatric nurse practitioner? Or are you being supervised perhaps by a family physician? Because, you know, that's an interesting dilemma. We don't have very many psychiatrists in Maine to begin with, and that's one of our problems.
I don't know the answer to that, but I think unless Senator Brenner, did you want to respond to that? Do you know the answer?
No, I don't. I think that would be a Board of Nursing question.
Yeah, I agree. So at this stage, just mindful of the time and the amount of work we have left on our plate for today and our need to take a break at some point, Colleen, if you could just record that question, and then we'll come back to all of these questions. Are there additional questions? There were hands raised and now there aren't. So I just want to make sure any other information requests for Colleen, things we need to know or be able to wrap our heads around in order to come back to this conversation. I think that's where we are right now. Representative Evans, go ahead.
Thank you, ma'am. Also, one of the clarify, there's a number of board certification programs. There's a total of 183 different nursing certification organizations. So I would like for them to comment on that.
Representative Evans, I think your question is similar to the one you asked earlier about the acceptance rate for nurse practitioner programs across the country and the number of programs that are available, but you were breaking up a little bit. So you're breaking up still and frozen. So if you could just send Colleen an email if we've misunderstood your question, and she'll put it on the list. But I think it was around the training programs. So we'll certainly get her to look into that. And I'm sorry that you're freezing on our Zoom. I apologize. I wish we could have great broadband everywhere in the state. All right. Is there anyone else who wants to ask for an additional information request of any kind, or wants to weigh in on LD 279 at this 270? I'm not even sure what number we're talking about. 275. Sorry. 295. Goodness. I don't teach math. All right, so LD, yes, whatever number we're on right now. Anybody else? Yes, Representative Quinn, go ahead.
Just speaking to the earlier issue of the rural communities are the ones that are being served more by the nurse practitioners and PAs as a whole. Is there a way to get the data to see how many NPs are providing primary care up in like Aroostook County in Washington County going forward, just to have that data? I see.
We can certainly look into that, or maybe, I think it might be harder to understand the percentage of people providing primary care who are NPs, which might be also the question or part of the question. Yeah. Okay. I'm gonna just give folks on the committee another shot to say if people want to weigh in here or ask for additional information before we table this. Okay, seeing none, so I will entertain a tabling motion. I think Representative Tepler muted herself while tabling the bill. Go ahead again.
Yes, I did. Sorry about that. So moved. Unmute, mute, whatever. So moved, Madam Chair.
Second.
Okay, great. All those in favor of tabling the bill? All right, we will return to this in work session likely after our session days next week, so that we have a chance for Colleen, who's going to have a lot on her plate between now and our session, to focus on those things rather than prepping for a work session on Tuesday. So we're unlikely to work the bill on Tuesday, just for the information of all those folks. I know there's an awful lot of attendees who have a lot of interest in this bill. So just to give those folks a heads up that we're not likely to pick this back up until the third week in March. All right. With that, I think we should take a lunch break just to review what our work for the afternoon is. We will be opening a work session on LD1 immediately after our lunch break. With a revised red line or a discussion draft that Colleen miraculously prepared with very little notice when I asked her to do so after the close of business yesterday. So, and I woke up to it in my inbox. So I want to just like highlight how hard Colleen has worked and how quickly she pulled this together based on our conversation on Tuesday. It is a discussion draft and it has been sent out to our IP list. It's been sent out to a number of folks who've been commenting on the bill throughout, as well as to the committee. So that's what we will walk through immediately after lunch. And the goal is to vote on LD1 today. So just keeping that in mind and preparing accordingly, if you guys wouldn't mind, would be great. So with that, and after LD1, we are going to hear, or we're going to have a discussion on the budget. And I plan to go quickly through the initiatives that were listed in our part of the budget. I think most of them are non-controversial. And then we have some information from Commissioner Head as a report back for questions that I raised, Representative Tepler raised, and Representative Quint raised. And so we'll go through those after we do a straw poll on the other parts of the budget that were not related to those questions. Does that make sense to everybody as a way to proceed? So I would direct your attention to Commissioner Head's email, which came in while we were in this meeting as well, responding to those questions, particularly her response to both us and the AFA, which answers Representative Quint's questions, I think. No, they weren't your questions, Representative Quint. I apologize. They were Representative Arata's questions.
They were Representative Arata's.
I'm confusing the two of you, so I apologize for that. I think you might have been in the same box in my Zoom square when you asked those. So I apologize for that. All right. So in any case, that is how we will proceed today. So I think it makes sense to take a good hour lunch, come back at 1:30 today. All right. Great. We'll see you at 1:30. Okay, I think we've got a quorum. Is Representative Morris with us or just not quite back yet? Oh, no.
Yes, no, I'm here. Yep, I'm
That's what
here.
I thought. I suspected you might be. So, all right, with that, let's get started on LD1. So we are reopening the work session on LD1 at this stage. And as I mentioned before we broke for lunch, we did circulate a red line draft, which was Colleen's attempt to capture our discussion on Tuesday and some subsequent sort of discussions about what we were trying to accomplish in Section B, and a number of other kind of things that we had talked about with regard to LD1. So I'm going to have her screen share it and walk us through the red line, and just kind of want to go section by section as we did before, but this time we'll be in the actual bill draft, and we can talk about whether we have concerns about each part as we go along.
Sorry. Here we go. I had too many windows open. Here we go. So this is the draft. As Senator Sanborn said, it's intended to try to help the committee make, for purposes of your discussion today, and kind of frame things up in our, so you can see the language and some red line suggestions. Let me try to make it bigger a little bit. So I'll just take you through it, where the changes are as we share. The first change is here, and this would be a proposal to add this language to Part A. So this was a provision that was not included in the amendment that was shared by the sponsor, President Jackson, at the public hearing, but I think it further clarifies his intent, because there's a corresponding provision related to this in the draft amendment. But this would clarify that out-of-network providers may not balance bill for COVID-19 screening and testing. And so it just adds a cross-reference to the existing law that prohibits balance billing. And some of the language may need to be, the intent is there. I may need to wordsmith it a little bit, but that's the intent, would be to make it clear that a provider, an out-of-network provider of COVID-19 screening and testing is prohibited from balance billing. Okay, I'll just keep going. I don't see any hands. If people want to ask questions, I think I can see that, but that's the first change in red. The second one, this is the provision that relates to providers again, and it would require providers to provide prior notice of costs and other information to individuals before providing screening or testing services for COVID-19. It does define COVID-19 as sort of the current virus or any virus mutations, but it would apply as it's drafted beyond the scope of the existing emergency. So, if it would be a permanent change in the statute. So any future vaccinations for this COVID-19 virus, the notice provisions would continue to apply. So,
Colleen, just to clarify there, because I think you just misspoke, this notice section only applies to screening and testing, not vaccination.
Oh, yes, it does. I'm sorry. But yes, you're right. Excuse me. But it would apply beyond the scope of the declared state of emergency if and when that ever ends. So the provider notice provisions have been modified somewhat. Paragraph A, just adding some language there, clarifying that the provider would be required to provide notice of any payment or upfront charge and the amount of that charge that would be due from the individual before receiving those screening or testing services, and information about whether the provider would submit a claim on their behalf or whether the individual would be responsible for that. You'll see it strikes out some of the language in all of the language in paragraph B. It modifies paragraph C to require the provider to provide the form for requesting coverage from DHHS through emergency main care program if the individual is uninsured, and also would require, with some amended language here in paragraph D, that the individual, if they're required to make an upfront payment, that there are other locations available and identified on the state's publicly accessible website where they may be able to access screening and testing services without any upfront payment. So that's the first subsection. The second subsection relates to language in the amendment that prohibits providers from charging uninsured individuals any amount associated with administering a COVID-19 vaccine or any associated cost of administration. Clarified this language somewhat, but again, I would just note that this would apply beyond the scope of the existing emergency. So if their providers are currently being reimbursed, as I understand it, for these services, but they would continue to have to provide them to uninsured individuals at no cost.
Colleen, I think consistent with what you've changed the language to be in some other parts of this redraft, we should strike the such as clause.
Yep, I can do that. I made a note of that myself as I was going through it. So I can do that. Then the rulemaking provision that would authorize rules remains unchanged. So that's the notice piece. Do you want to talk about each piece individually?
Let's stop there for just a second. Another thing that I noticed, if you scroll back up a little bit, is that emergency main care and the state's publicly available swab and send sites might not survive they might not always be around. So I think it
wordsmith that.
Yeah, just something like to the extent they are available, or if applicable, or something like that on D and C. Are there other comments from the committee on what we've gone over of the red line so far, which is the sections that modify Title 22, the provider statute? All right, I don't see any electronic hands up. If you have your physical hand up, I won't be able to see you. So Representative Tepler, go ahead.
Thank you, Madam Chair and Colleen. I'm just, what does inform mean technically? I mean, how are we informing? Are we requiring them to post it?
So Representative Tepler, I think we received testimony that for the most part, COVID screening and testing is done by appointment, and that most of our providers have online portals for scheduling those. And so it would have to be part of the online portal experience.
Okay. And this is in the testing and screening.
It only applies to testing and screening.
Right. Yes.
Is that are you And Colleen, if you want to scroll up, you can see the beginning of that paragraph, which does have some wordsmithing to it.
Mhm.
Yep.
So it says at the time the individual schedules or registers for screening and testing services. So if it were an in-person encounter at an urgent care facility, for example, then that would be at the, you know, at the time you're giving your initial information about who you are, you know, at the clinic. So you have further questions about that, Representative Tepler?
And we were concerned that the individuals might not know how to make that claim on the charge that would be due from the individual. Is that something that we can just reference the navigators or the consumer bureau on?
So yeah, this request or this notice requires that you be told that the provider won't submit the claim on your behalf.
Right.
But we did take out the requirement for instructions on how to submit, because that would include like different website addresses for your different carriers or different 800 numbers or those kinds of things. So I mean, I think flagging that it's not going to be sent to your insurer is probably, you know, explicitly flagging that is a pretty far step to go. We don't usually do that. We don't make providers usually do that. And I thought including the emergency main care form was actually potentially more important.
That's probably correct, yes. Okay.
All right, Colleen, does anyone else have any comments on the Title 22 sections of the bill? All right, let's move further on then.
Okay, so the next section relates to, excuse me, health insurance coverage of both screening and testing and vaccines. And it's sort of split onto 2 pages, but again, it defines, you know, COVID-19 to mean the current virus or any virus mutating therefrom. So it doesn't include other related coronaviruses that might come up in the future as it's drafted. The first provision here in subsection 1 covers or relates to screening and testing. Essentially, it would require carriers to provide coverage for screening and testing except for surveillance testing, and there's a definition proposed there for that. No cost sharing. They can't make coverage contingent on or dependent on any prior authorization requirement. There are provisions related to whether or not, can't make it dependent on whether the provider is in the carrier's network unless the enrollee is offered the chance to have a network provider and the enrollee instead chooses to obtain it from an out-of-network provider. But really the changes to the original proposal made to the committee are in paragraph E here, and you'll see this was intended to try to clarify the issues around administrative costs. And so trying here to specify that the carrier reimburse the provider for the costs of screening and testing, including all associated costs of administration. This tracks some of the language in the existing insurance emergency order. So it does remove that explicit reference that was originally included related to facility fees that there were some concerns raised about. And then it maintains the provision or the language at the end of paragraph E that would treat bills for out-of-network COVID-19 screening and testing as a bill for out-of-network emergency services. So someone would have the opportunity, it would define or scope of the reimbursement for those services, but also would allow the ability for disputes to be heard through the independent dispute resolution process. That's screening and testing.
So Representative Morris, go ahead.
On here. Thank you, Madam Chair. So I know we got some testimony in this afternoon late from Anthem in where they administer the state plan, and that impacts the fiscal note. I noticed they added some language under after reimburse a provider for the cost of COVID-19 screening and testing, including all associated costs of administration. They added language, they'd like language added, authorized under a contract between the carrier and the provider. And again, where they administer the state plan, you know, this bill will have a fiscal note, so.
Yeah, I certainly saw that testimony from Ms. Ossenford as well over our lunch break. And my concern is the testimony that we heard from Northern Light and from Maine Health, that they didn't anticipate COVID-19 at all when they negotiated their last contracts. And so there's no reference at all to COVID-19 screening and testing in those contracts. So I was quite concerned that that might be a loophole that swallows the rule, you know, and that it also might be us wading a bit too far into contractual relationships. You know, in-network providers have to follow their contract with the insurance company, and insurance companies have to follow their contract with the provider. And I'm not sure adding that to this paragraph actually changes the meaning of this paragraph in any way, shape, or form, other than potentially to play gotcha to the provider, because there's no COVID-19 reference at all in their contracts. And then they'd have to scramble to get that done in the middle of, you know, an emergency situation. So I that was my concern, Representative Morris.
Okay.
Ms. Ossenfort has her hand raised, and since we're talking about her testimony, I think it's fair to invite her to join us to tell us why what I just said is wrong. And Ms. Ossenfort, just go ahead and unmute yourself when you join us, because I can't see you.
Yeah, I can't either.
Okay, thank you, Senator Sanborn and members of the committee. What we were suggesting wasn't intended to be a gotcha, but rather we don't know what associated costs of administration is intended to refer to. Thinking back to the prior version where it mentioned administrative fees and facility fees. As I mentioned in our letter, you know, we're concerned, does that mean if they set up a mass vaccination site that they can then tack on additional charges? So we were just trying to confirm that, you know, the associated costs would be something that is covered under their contract for, you know, such as facility fees are governed by the contract. So certainly happy to work on additional language, but that was sort of the intent, was trying to narrow down what is associated costs of administration.
Yeah, so let me reframe this a little bit, Ms. Ossenfort, because the verb has kind of changed here. And I think that when the verb changed, it kind of also gets us off track. So Section E originally talked about what the carrier shall provide coverage for, which is, in my view, a consumer protection issue. But then now it says shall reimburse a provider for, which becomes a provider protection issue. And I don't necessarily think there was an intention of flipping those two things. So what I'm trying to ensure is that a consumer has coverage for whatever costs are billed. Because otherwise, what happens is that they get a denial for some portion of the bill, and then they have to pay that, not as a balance bill from the provider, but as the insurer saying it's not related or it's not part of the mandated coverage. And that's what I'm trying to get my arms around. So, I mean, we could eliminate this section entirely, but this is my concern, is that I want to make sure that nobody's getting a bill for any part of their visit for their screening and testing. And I'm trying to capture what all associated costs of the screening and testing is. And I feel like we all know what we're talking about. And that's what is very frustrating here. Because from my view, it's a consumer protection issue. The provider and the carrier have their own contracts and they have to abide by those contracts. So I'm not trying to override your contracts, but what I am trying to do is to protect consumers. So I would really be interested in help with that.
I understand. And as you said, we all know what we mean, but trying to find the words to capture it is challenging. I mean, I'm looking back at the federal FAQs to see if they could provide some guidance, because they talked about, sort of when those types of fees are appropriate or what types of fees would be covered. So if it's related to the visit and it's part of the charge for the visit, as opposed to, our concern is, and I'm not saying that any providers intend to do this, but our concern is those add-on fees that are not part of the administration of the vaccine or related to the healthcare services that are being provided, the clinical evaluation, or so I'm certainly happy to try to work on some language, but like you, I'm struggling with what the words should be at the moment.
Okay, well, I think that this language, and I think the reason that Colleen used this language is because it better tracks the Bureau of Insurance rule as it stands today. Colleen, can you speak to that?
Yeah, I mean, I was just trying to clarify. I mean, the Bureau's language does use phrasing like such as processing fees and clinical evaluations, but
okay,
I did take that out because I was trying to,
okay,
I didn't include that, but it does refer to all associated costs. So I did use that phrase to try to track that when I was going back and looking at it. I know the superintendent might want to weigh in, but
yeah, let's bring Superintendent Chapa in. Thanks, Superintendent. Go ahead.
Good afternoon, Senator. Yeah, when we drafted that, admittedly, we don't usually get involved. I think you hit the nail on the head. This is usually a contractual issue. Facility fees is part of the contract, and COVID-19 is a novel event. And we admittedly had the same goal, is to keep the consumer out of the middle of that and to pay all the associated costs of administration. And I think you made the statement that I think the elephant in the room is who pays for the mass vaccination sites and the administrative fee. And that's, in my opinion, that's, we didn't really get to that level of granularity when we were discussing it internally when we developed the bulletin, because we didn't realize that would be an issue. But I think that's probably what's going on, is and that's really a committee decision. But our goal was the same as you, is to keep the consumer out of the middle of that discussion. We didn't feel that the consumer should pay for it.
Right. I mean, just to point out, this particular paragraph we have on our screen has nothing to do with mass vaccination.
Exactly.
This particular paragraph is only about screening and testing. So,
right.
I wonder if we shouldn't go back to a carrier shall provide coverage for, for the consumer. Like we want to focus this paragraph on what the consumer's coverage is. And the question of what they reimburse the provider for is left to the contract, is left to their agreements.
Right. That was our perspective as well.
I mean, perhaps you could redraft it to say a carrier may not charge a consumer or require a consumer to pay, or an enrollee to pay for the costs of associated costs of administration or something like that. You might be able to narrow it or focus it that way, perhaps. I don't know.
Okay. Representative Morris?
Yes, thank you, Madam Chair. I absolutely agree with what you are saying. We do want to keep the consumer out of this question. I think what we're really after is just to have it, to when this law takes effect, have it continue to be going as it is going now, and making sure the language is clear on that piece. Because, as I said, we want to avoid a big fiscal note on this bill.
Yeah, for sure. I agree. Representative Evans.
Thank you, Madam Chair. It may be best to insert the word consumer so we know it's clear cut.
Yeah, it wouldn't be consumer, but it would be enrollee. Yeah. And so I think it would, it should be clear that the carrier can't require the enrollee to pay any of the costs associated with the encounter.
Administration. Yeah. Okay.
Yeah. Representative Morris, your hand is still up. Is that okay with you?
Yep. Sorry, I just left.
No, that's okay. I wanted to make sure you hadn't raised your hand to comment again on that topic. Okay. I think Ms. Austin-Ford, are you still with us?
I am.
Okay. Does that allay your concern to some extent, because it doesn't actually do anything with regard to what the level of reimbursement or the elements of reimbursement are?
Right. I think that is a step in the right direction. I will try to think about it a little bit.
Okay.
A few minutes.
All right. Well, thank you. And, I will just point out, I think the use of the out-of-network emergency services provision with regard to out-of-network bills, is really key and useful to the carriers in this regard. So go ahead.
So our only concern with that was it also invokes the IDR process, which might be a bit much for this. So that's, I think, why we had suggested, sort of tying it to the reimbursement requirements and not bringing in the IDR, because that $750 in 80th percentile provides an opportunity to increase the cost significantly and still require us to pay them.
So, Superintendent Chapa, can you weigh in on that? Because she just lost me a little bit in terms of what the cap thresholds are for IDR. And I think you can help us with that.
You have to repeat it. I was commenting. I was planning a comment. I had a different.
Oh, okay. Ms. Austin-Ford, so your goal would be for us to exclude this from IDR and simply set it at median in-network rate as a reimbursement level. Is that correct?
In the statute, there's a greater of median and I don't have it in front of me, but median network or, and so, but treating it as an out-of-network emergency service also invokes the IDR provision, which we're not sure makes sense for out-of-network screening and testing.
Okay, but IDR only kicks in if there's over a $750 bill, right?
No, it's actually the opposite. It's if it's less than that, we automatically have to pay the charge, basically, less than the 750 or the 80th percentile.
Yeah.
I see. Okay. So I think your testimony suggested that we simply cross-reference it deeper down into the one paragraph. I'm fine with that.
Yep.
I'm fine with that.
Okay.
Superintendent Chapa, or does anybody else want to comment on this emergency billing issue? I apologize. Okay. Superintendent Chapa, what were you going to raise?
My general counsel came up with a novel, different approach. He said, we already prohibit network providers from balanced billing, and perhaps the associated costs should be struck from 2B rather than in the provider reimbursement section. Then the contract controls for reimbursing network providers and surprise billing law controls for out-of-network providers.
Okay, so it could be up in paragraph B. Is that what you're saying?
Yeah.
Can Colleen, can you scroll up so I can see paragraph B?
Yeah. Yes, you could. Yeah, you put it up there, right there. Yeah. So you'd combine. You'd like move it up. Is that what the suggestion is?
Let's bring.
Yes.
Okay. Yeah. So we're bringing Bob
That
Wake?
would be fine.
Yes, let's
That's a
bring
more
Mr.
straightforward
Wake
draft.
in. Mr. Wake can help us make sure we're in the right spot. Mr. Wake, go ahead and speak when you're in the meeting because we can't see you.
Okay, so what I was proposing was that a carrier may not impose any deductible copayment, coinsurance, or other cost-sharing requirement for the costs of COVID-19 screening and testing or any associated costs of administration.
I love it.
Yeah.
Great.
Yeah.
And then you'd have similar language on the vaccination.
Right.
Yep. I think that works. Does
And then
anybody have any?
you separate the reimbursement.
Right.
Right. And we don't need to speak to reimbursement except for out of network bills because everything else is governed by the relationship between
Right,
the
and we've
provider.
spoken elsewhere to reimbursement for out-of-network bills.
Correct. Okay.
Okay.
Great. Thank you. All right. Does the committee have any further comments on this particularly weird wordsmithing issue? All right. Ms. Ossenford, I'm not going to put you on the spot, but I feel like we've addressed the concerns there.
All right, thank you, Senator.
Yeah. All right.
Okay.
Colleen, can you scroll down?
I think it'd be the
and-
same fix then for the vaccine provision because it was the same language. So the only thing I would point out is that there is a distinction between the treatment of an out-of-network essentially bill for screening and testing and vaccination. There's no similar cross-reference to 4303C here for this provision. So,
Okay.
so people know that.
Ms. Ossenford, go ahead and comment on that.
Thank you. CMS has deemed the Medicare reimbursement rate as a reasonable rate. So if you want to address reimbursement for COVID vaccination, you may want to refer to the CMS rates, the Medicare rates, which CMS has already deemed as reasonable reimbursement.
Got it. I have a sense that we could perhaps just
not even
be silent as to that and delete section E. And then there are rules. There's a rule making provision that would allow the superintendent to step in and do that at some later time if we needed to, if the federal rules expired. So that's how I would proceed with that.
Yep. So
Are there other comments from the committee on that section? Okay. Seeing none, I'm going to lower Ms. Ossenford's hand. Okay.
Then this is the language here at the end is just recognizing that this would be considered a mandate under the existing definition, subject to review by the Bureau of Insurance. But this language would state that it would be exempt, move forward without that review. So,
any comments on that? Does the committee understand what that means? Okay, great.
Okay, so that was part A. And then part B had two pieces. One was related to prescription drug coverage, and the other was to the authority of pharmacists to administer COVID-19 vaccines. So the committee had a lot of discussion about whether it was appropriate to put the language in the prescriber sections, if you will, the licensing statutes, or whether this should be more directly focused on insurance carrier coverage. And so the suggestion here is to strike those references in the licensing provisions and replace it with this section, this proposed section that would require carriers to provide coverage for the furnishing or dispensing of a prescription drug in accordance with a valid prescription issued by a provider for an extended period of time not to exceed 180-day supply during a state of emergency declared by the governor. This language as drafted has the potential to go beyond the current emergency. It would apply to this emergency, but if there are any in the future, it would apply to them. And then the second sentence is really just intended to try to carve out provisions in existing law that either allow prescriptions of longer length, for instance, and that's the reference to prescribed contraceptive supplies. The current law allows contraceptive supplies to be furnished and dispensed in up to a 12-month supply. The second reference is to coverage of opioids, that there are some prescribing limits in the licensing statutes that limit the amount of opioids that can be prescribed. There may be some, there may be some further language that the committee wants to add to recognize other instances where related to controlled substances or pain, any sort of other licensing rules that govern prescription of other types of prescription drugs. This may need some further wordsmithing, but I think this was intended to try to get at the carrier issue. Would only apply to health insurance carriers. It wouldn't apply to folks who are covered under other types of insurance programs.
Before I call on Representative Evans, I just want to make sure that we understand where we are here. So what this purports to do is to take out any sort of licensing provision that was in the statute as drafted, and it really just focuses on the coverage by insurance carriers. I want to suggest that we insert the word statewide before state of emergency. I think that makes a lot of good sense. So if it's a statewide state of emergency.
Yep.
And also with regard to the question about other types of drugs that might be controlled substances. So I also just wanted to point out that those are all, any sort of drug that has additional rules about when and how much you can prescribe it are all in the provider side of the statutes already. And so this wouldn't change any of those provisions. This would simply require insurers to pay for the dispensing of a valid prescription in a larger quantity. So if a prescriber is only allowed to write you 30 days worth, then this paragraph has no effect. And I confirmed that with Ms. Cohen before the meeting started, that we didn't need to add anything else from a public safety perspective, because those are all in the provider side of the statutes already and wouldn't have anything to do with the way we've worded this now. Representative Evans, go ahead.
Thank you, Madam Chair. You just said what I was going to say.
Okay.
So,
Great, thanks. Representative Morris.
Yes, thank you, Madam Chair. I certainly agree with the idea with amending it to have it be a statewide emergency. I think that's a good idea. I just wonder if we might want to further clarify it, that it applies more to a public health emergency, or if that even makes sense in statute, if such a thing. But similar to what this is, because I think that's what we're trying to capture, is a situation like what we're in with COVID, where this is a public health emergency as opposed to a snowstorm or an ice storm or something, where there's a more limited duration of time.
Yeah, I thought about that, and I know that was in Ms. Ossenport's testimony as well. And my response to that is just that I'm not sure that captures, like, I could imagine us being like in a nuclear emergency or something like that. I mean, I hope we never are, right?
Yeah.
But I'm just trying to imagine, like, I never thought we'd be in this kind of year-long pandemic state of emergency either. That was not one of the things on my radar. So, I'm trying to not be too limited in the type of consumer protection that we're offering to people. And I think over the history of our state, a statewide state of emergency has been a pretty rare occurrence. But I was concerned about the suggestion that it be, anticipated to last more than 30 days. Because the statute requires the governor to reissue it every 30 days. So I'm not sure that those two things can make much sense together.
Yeah, no, I don't think, I didn't necessarily think that. I just wondered, to be more specific on this specific type Because,
Yeah.
you know, as you know, there's going to be debate as the session, not before this committee necessarily, but around, you know, emergency powers and so forth, and just trying to keep it as limited as possible.
Well, and let me suggest, Representative Morris, I hope gently, that part of what we're doing here as a legislature
Yeah.
is trying to, in advance, make some legislative determinations
Yeah.
of what the next
Emergency would
emergency
be.
should look like, or what this emergency should look like after the state of emergency, you know, goes away. Because a lot of the paragraphs in here do apply even if there is no declared state of emergency, and that's intentional, I think, because it is, to a certain extent, us doing our legislation, our job of preparing to protect consumers and to make sure that they have the health insurance coverage that they need in this emergency or in future emergencies. Or I guess I should use the word crises, right? Like in this crisis or future crises, without the governor being the only one who can make those determinations, because we've already done something in statute in advance. So I hope that actually helps to frame the issue, you know, in the flip way.
That is another way to frame it. Yeah, that is another way to frame it.
Okay, Representative Evans, go ahead.
You know, I agree. I think we should just leave it, because during a state of emergency, that could be any number of things. We don't know what the future holds. So I would leave it as it is, and we'll just have to deal with it. We don't go around every day just declaring states of emergency. You want to have something in place and not have to go through this process again.
Yeah. I did think that adding the word statewide was helpful,
That's
though.
a big difference.
Yes.
Yeah. Okay, great. Okay.
Right.
Are there other comments on this paragraph? All right.
I think we can, sorry, excuse me, Madam Chair. I think we can discuss, you know, it more at the end if we want to get through the rest. But I know through our caucus, we've been discussing that we would like that amended down to 90, to a 90-day supply instead of 180.
Okay. Well, 90 days is what is standard coverage today. So then this paragraph does not do anything.
Well, I think, well, you just change the 180 to 90.
No, I mean that it's an insurance mandate, and the current practice is for insurers to cover 90 days. So if we
Okay.
amend this paragraph down to 90 days, then we might as well just strike it from the bill. And I understand that the insurers have asked us to do that. But as I just mentioned, like, I think there's a good rationale for putting this in place as part of our job of preparing to set the stage for this outside of executive power.
Okay. Well, all right. Well, we may need to caucus on that again,
Sure.
but
I expect we'll caucus briefly before we vote on LD1. To be clear, there's a lot here.
Yes.
And we haven't had very much time with it, but that's because you know, we're really just working hard to try and finish it because we are in a state of emergency. Representative Tepler, go ahead.
Yes, thank you. I just wanted to respond to Representative Morris that I currently receive 90-day prescriptions for all my standing prescriptions, but that would keep me going back to the pharmacy at a time when I might not prefer to go to the pharmacy as often as I do now. If I had a 180-day prescription, there would be a longer period where I didn't have to actually go to the pharmacy to get my medication.
Yep. Okay. Colleen, let's keep scrolling.
Okay, so if we scroll through the rest of these are just taking out the provisions, as Senator Sanborn mentioned, that we're proposing changes to the licensing statute related to the 180-day supply. But scrolling down, this provision was included in the original amendment proposed to the committee, and this would remain unchanged, but it does authorize pharmacists licensed in the state to, in addition to their existing authority to already administer influenza vaccines and other vaccines that are authorized in statute, to administer and order COVID-19 vaccines. One thing I remember we talked about, and this isn't clarified here, and I don't know if it should be, it was suggested that we add reference to billing to this provision to clarify that they be able to bill. And I don't know if that's something that I might have overlooked that, but I just want to double check on that and raise that for you. But there were no changes otherwise to this section. The Retail Association had suggested adding some specific language about allowing them to delegate authority beyond the state of the emergency. That has not been included, but I would point out that when we get to Part D, the Part D language does address delegation at those vaccination sites that have a memorandum of understanding with the state. And then also under federal law, which is referred to as the PrEP Act, pharmacists do currently have the ability to delegate authority during this current state of emergency.
Yeah, thanks. Yeah, we did consider the question of adding back in pharmacy techs and students, and decided not to because the provisions for training and the incorporation of the federal rules was not in the section of the statute, and so it would have given a blanket authority of delegation without ensuring proper training. And so I think we left it just to the federal language instead for this section. With regard to billing, I think I'm inclined to just kind of leave that piece out for now, knowing that we're going to keep working on that subject throughout the committee's work in the rest of the session. But that would be my inclination. Are there other comments on this section before we move on? Other comments from the committee, concerns? All right, seeing none, we'll keep scrolling, and I apologize for my parents' house phone, which is ringing in the background.
Then, like with Part A, there's a provision that would be added to Part B related to the first section we just talked about requiring carriers to provide coverage for up to 180-day supply. That would be considered a mandate under Section 2752. So this would include similar language stating that if it moves forward, it would be enacted without a review and evaluation by the Bureau of Insurance.
Okay, I think we can keep scrolling.
Part C, the proposal is, as the committee discussed on Tuesday, to defer discussion about making changes, permanent changes to the telehealth provisions to when you discuss a number of bills that have already been printed and some still to come related to that issue. So all of Part C is deleted. And then we come to Part D, which this would be an unallocated section of law. It would only apply during the current state of emergency. And this would provide some authority to permit delegation of vaccine administration at point of dispensing vaccine sites, where those sites have a written memorandum of understanding with the Department of Health and Human Services. So the language here would permit that delegation. We did add two clarifications, one specifying further that it only applies to this state of emergency related to COVID-19. So it adds a reference to the first date of when the emergency was declared by the governor, which was March 15th of 2020, and the subsequent renewals that she's made of that declaration. Because as Senator Sanborn said, the governor is required to do that every 30 days. And then it also adds some clarification that with regard to the on-site clinician in charge, that the person, it doesn't have to be just one person that's responsible for that delegation, but any on-site clinician in charge that has undergone the proper training may delegate that authority at the site. And then it also adds those references to any on-site clinician And then also adds in the requirements that the on-site clinicians who may have authority to delegate would be identified in an addendum to the memorandum of understanding. So those are the two technical changes with regard to Part D. And that was it. I did make some clarification to some of the summary just to specify where the changes were made, but that's the discussion draft.
Great. Thank you, Colleen. I think that really advances the discussion an enormous amount. So if we stop screen sharing for a moment, and we can go back to the language if we need to. Yep. Is there committee discussion, or are we ready to break for corner caucuses? Representative Bleier.
Thank you, Madam Chair. I just want to discuss the 90-day prescription a little bit more. Can we do that?
Sure. Yeah.
All right. So, I guess where I stand on that, I mean, God forbid we have a nuclear attack, but chances are if we do, you probably won't need a 100-day prescription because you probably won't be here. So the point behind that is that I think we could strike that from the law. I think that 90-day prescription is sufficient. If we're going to 180 days, I know there's medications out there that 180 days with a prescription is not that big of a deal, but there's probably others that there could be creating a lot of waste within the prescription drugs. And so, 180 days is a long time. I think 90 days is a long time. Now, I've been around 50 years. I've seen ice storms for a week, but this is the first time we're in a crisis like this. So I get that we're trying to solve this particular crisis, but we don't have a multiple of, we haven't had in 50 plus years, a lot of crises like what we're in, but we've had a lot of ice storms and snow days. And so there'd be a lot more chances of prescribing 180 days with a medication for instances where they're really not needed compared to the crisis that we're in today. So that is my concern on that particular line item in this bill.
Thank you, Representative Bleier, excuse me. Representative Tepler, go ahead.
Thank you, Madam Chair. You okay?
Yeah. Okay.
So I want to respond to Representative Bleier a little bit because as a person with type 2 diabetes, I have a set of medications that I take regularly. And I believe that this is not about the prescription of those medications, but about payment for them. So if my prescriber decides that it's okay for me to have 180 days of my medication because it's safe, because it's the medication I've been on for 10 years and have taken the exact same dose for 10 years, then my prescriber, she can prescribe that amount. And but the question is, will the insurer pay for it? So this bill addresses whether or not my insurer will pay for it, not whether or not my prescriber will choose to make that prescription. I'm not telling my prescriber how to practice medicine. I'm just saying that as a consumer, if my prescriber wants me not to go to the pharmacy very often because maybe I'm vulnerable in a particular situation, or because we're worried about a chain of supply issue, which I think became an issue for me with one of my medications this year, then my insurer will pay for that. So that's really, I think what's embedded here is asking my insurer to pay for what my prescriber deems to be reasonable.
Right. I just wanted to add, Representative Bleier, I was thinking more of like Fukushima, which I think is an example of a disaster that would be more of the nuclear type that I was concerned about. We're not likely to have that happen either with Maine Yankee closed, but that was sort of what I had in mind. And one could imagine a situation where a large number of people were going to have to travel out of state, for example, or other types of natural disasters that might occur. But, you know, yeah, I don't think this is going to happen very often. I don't think we're going to have statewide states of emergency very often. But as I was talking to Representative Morris, it's our job as a legislature to do what we can to make sure that the ball's in our court and not the governor's court where we can and where we can anticipate these kinds of consumer issues. So I think this is one of those, it kind of cuts the other way, right? If we want to have a strong legislature, we've got to make these types of determinations ahead of time, because it's quite likely we won't be in session when the next pandemic strikes. And I am actually worried there will be a lot more than there have been in the last 100 years. I think that's unfortunately what the science tells us might happen. Representative Blair, you had your hand up. Go ahead.
Yeah, I'd like to follow up with Representative Tepler. And if you get 180 days supply, and this is about the insurance company paying for the 180 days supply, 3 months into it, you lose 3 months worth of supply. And so you go back to get a resupply. Does the insurance company have to again pay for that 3 months supply that you just lost?
Representative Tepler, go ahead, you can answer.
Thank you, Madam Chair. And Representative Blair, my prescriber will not prescribe more medication generally until a week before the supply that I'm supposed to have runs out. If I were to lose some medication or something were to happen, I would have to have a careful discussion with my prescriber about that. And then we might have to seek an insurance exemption of some kind to get it paid for. Just like, I don't know if you take any medication, but when I go on vacation, if it looks like my prescription won't last through that time period, I have to request a vacation exemption so that I can get an additional supply of my medication before I leave, if I'm going to be gone for longer than a period of time. So if I go on, say, a 3-week vacation and my prescription is running out in 2 weeks, usually I'm not allowed to refill at that point, but I can get a vacation exemption to refill at that point so that the insurer will pay for it and my prescriber will allow it.
Yep. Representative Brooks.
Yes, I think that a lot of medications, if not the vast majority of them, are really prescribed to prevent an illness. Like I'm thinking of, with diabetes, requiring insulin, it's absolutely required. Or people that have atrial fibrillation, if they're not on the blood thinners, they could have a stroke. There's a high risk for that. So I believe if we're in a state of emergency, a statewide state of emergency, the greater risk is with patients running out of their medicines. And a lot of medicines are, ideally they would be kind of stable for a while. And I think also that how it was referenced that the provider and patient would have to make a clinical decision, whether the 180 days is appropriate, and also with the risk of contagion or an infectious disease. I know a lot of people that have been staying real close to home.
Yep. Representative Arford. You're on mute. You're still on mute. Still on mute, Representative Arford.
The boxes kept moving away from me. Sorry about that. So this question may have been asked, and I apologize if I'm repeating it, but was there a reason stated for why prescriptions were limited to 90 days up until now? Was there a reason? It wasn't just either a limit of 180, 120, and at the discretion of the prescriber?
It's the question of how much insurance will pay for.
No, I know, but why was the law written before that was limited to 90 days?
There is no law on it. the current practice is generally that insurers
Oh,
will pay for 30 days or 90 days.
So our law,
Usually in order to qualify for 90 days, you
Okay.
have to go through a mail order pharmacy, depending on your insurer,
right?
depending on your policy.
Okay,
But,
so the
yep.
state had no role in that up until now. In other words, now we will be requiring insurers to pay up until 180 days, whereas before we had no role in how many days they paid for. They decided, the insurance company decided themselves.
With regard to contraceptives, contraceptive supplies that are done by prescription, we passed the mandate on insurers that they provide 12 months of coverage upfront at one time. We passed that bill a few years ago, but with regard to other types of medicine, there's no statute.
Thank you.
Okay. Representative Evans.
Thank you, Madam Chair. I just wanted to go back to Representative Blyer's concerns. Ordinarily, a prescription is written either for 30 days or it could be 60 days. It's usually no more than 90 days. That's generally speaking. I think in this case, we're talking about the exception where you would need the 180 days, and Representative Brooks had indicated certain conditions where you want to make sure that that patient does not miss the medications under any circumstances. So the 180 is in an emergency situation. It would be extremely rare, and I don't expect anybody to start writing prescriptions for 180 days.
Representative Tepler.
Thank you, Madam Chair. I'm sorry to speak again, but I want to sort of present a what if that I feel that this bill covers. So if, for example, we had a situation where a hurricane flooded the whole Maine coast, like Katrina, let's say, and we had to actually leave our homes for some period of time. If I were able to stop at my pharmacy and pick up a 180-day supply first because I had to leave my home, I wouldn't have to worry about whether or not, if I'm going to, say, Pennsylvania, where I have some family, they would honor my prescription or not. I would have my 180 days of several of the medications that I take regularly, one of which, if I don't take it, I will be slow down quite a bit and maybe get a goiter, and that's very common actually in women over 50 years old. So that's kind of how I see this playing out, is that we're preparing our state for emergency situations. This is a preparedness kind of approach that's not just addressing this emergency, but the potential for patient harm in future emergencies as well.
Okay. Are there is there further discussion regarding this section of the bill? Representative Brooks.
Now, I would just point out too, a lot of my medicine has a 90-day supply, but it also a lot of providers will give a number of refills. So with a 90-day supply, it is relatively common to get refills, and the provider and patient feel as though they may not need to be clinically evaluated every prescription refill.
Mm-hmm. Okay. Are there additional comments from the committee on other sections or any section of LD1? Representative Morris.
Yes, thank you, Madam Chair. So we did discuss in caucus today that we do want a sunset clause, at least on the testing provision. We think through December 31st of 2023. That gets us through the first session of the next legislature. An opportunity for us to review it, to review the provisions of the bill as far as the testing and how it's going, and if it makes sense to renew it at that point. But we do feel very strongly that we would like to see this sunset. I think, as I said the other day, we're still kind of in the fog of this right now, still very much in the emergency, and we want to absolutely do all the consumer protection piece when the state of emergency ends, make sure people are still able to get their tests, all of that. But I do think it makes sense, rather than keeping it on the books for this one specific disease, to review it in a couple of years with the testing and see again. If it makes sense to renew it, then I'll be the first one to vote to renew it. But I think it needs to be discussed.
So thank you for raising that. We discussed it as well. I think we feel strongly that we haven't the foggiest idea when we're going to be out of the fog. So we agree we're in the fog. We think when things clear is a good time to revisit it, and we don't know when that'll be. And that's what the legislature is for, is to bring up a bill to repeal things. And it's just as easy to do that as it is for us to bring forward a bill to renew something that would otherwise expire on its own. It's literally the same process. But the question is whether we want people to be protected if there's like a resurgence of COVID in 2024 just before we come into session, or just as we're coming back into session, right? It takes us months to pass bills. It's March 4th already. This is LD1. We haven't passed it yet. So again, do we want the governor to be the one who decides if your tests are paid for on January 1st, 2024? Or do we want the legislature to be the one who decides? I want the legislature to decide. That's my elected role. And so here I am deciding this should be covered until future notice. And at some future time, we can normalize the treatment of COVID-19. And hopefully we never have to call something COVID-24, but we'll have to figure out if it's still COVID-19 or if it's a new thing, right? But this only applies to COVID-19 and its mutations. And if we have a re-outbreak of it in that winter of 23-24, I do not want this to expire in the midst of that outbreak. And of that resurgence of the pandemic. And that is far less far-fetched than some of the other scenarios, Fukushima or whatever, that we have talked about on this in this meeting so far. So I feel very strongly that we should not have a sunset on this, because inevitably the virus will reoccur at a time when we are not in session, or when we just, frankly, it takes us 3 months to pass a bill, even if it has an emergency clause on it. So that's, I think I speak for my caucus with regard to the sunset clause and that really being our legislative prerogative to repeal a bill instead. Representative Bleier.
Thank you, Madam Chair. And that's what is great about this process is we can agree to disagree. And so I think my positioning would be that we will be doing our legislative work if this is still around in 2023. And so I think that being able to have a different set of eyes looking at this at that time, after this has gone through, that might, we can see the good about it, the bad about it, and come to a new decision on how to best move forward, I think is important. So having a sunset clause, I think, is extremely important on my behalf. I think that that's the way I would see it, to have a new set of eyes, new communication, because COVID's been around for a long time. This one's just called COVID-19, but cold is basically a cold. And so, I think that, in my opinion, I don't know if COVID is ever going to go away. It's just going to be a continuous of COVID, no more flus. This is just what it's going to be every year. So I think that, that we need to relook at it on 2023 and come up with a new decision on how we best move forward as a legislative body governing the state. So that's kind of my positioning on it.
Representative Tepler.
Thank you, Madam Chair. And I guess I just have to ask my colleagues, I don't understand what the potential harm of creating the law going forward is. In my mind, it might be costing our insurers more money during the crisis, but if there is no crisis, it won't be costing our insurers more money. So I'm confused about what the harm in keeping the law moving forward is.
I can address that, Senator.
Representative Morris, go ahead.
Yeah, I think the concern is that this is a unique virus and we're setting this precedent of putting this in, and then the next virus comes along and we add that in and add that in. And I think it is part of our job to be reviewing it, and by requiring a review, if it sunsets, then we have to review it and see if it makes sense to renew it, if this is still a concern, because as I think we're doing a very good job from what I've seen getting the vaccines into arms. The cases seem to be falling. And at this time last year is when they were really ramping up. So, the cases seem to be falling. We're getting more tests. We're getting these vaccines in. So eventually, at a certain point, we'll reach that point of, what they call herd immunity. And so I guess it's a situation of it is our job to review these things periodically as well and see if it makes sense to continue it going forward. So that is our reason why we'd like to see this be sunset.
Are there other comments from the committee? Representative Bleier.
Yeah, and I just want, so I guess my biggest concern is that, I haven't been doing this a very long time, but we very rarely ever repeal laws. We just create more and more laws. And so I think that, I understand the concept that this is protecting the consumer. And I agree with that. I think, but things will change over the next 2 years. So let's get a new, fresh set of eyes to look at how to best protect the consumer at that point. Would be more, because it's going to change. And so I think if we don't make it sunset, it'll just be, we won't even really think about it, and it'll just keep moving forward. So that's my thought.
Representative Tepler.
Thank you, Madam Chair. I guess I'm still confused about what the harm is if it just sits on the books. Yeah, we have a lot of defunct laws sitting out there that we don't pay any attention to anymore, and maybe we should clean them all up, but I'm not sure where the harm lies. I'm still confused about the harm. Fresh sets of eyes are always there because of our term limits. I won't be here, but I'm very confused about what the harm is in waiting, in holding it.
Representative Tepler, you mean to say that because we're talking about a testing provision, if the virus isn't circulating in our community, then it's very unlikely that people will be getting tested for it in any great number.
Or at all.
Or at all.
Really is gone, yeah.
Right. If it's gone, this will just sit there as a mandate that no one really uses. Because we don't just go get tested for COVID for fun. That would be a strange thing to do. But at the same time, if, for example, in 2024, I travel to, East Africa, where they're still struggling to vaccinate, and then I want to get tested on the way back, I think we are in a situation where we want to make sure that those tests get done and get covered as expected. Rather than suddenly not being covered on January 1st of that year. So that's how I would frame it in terms of the harm of a sunset clause. Senator Brenner.
Thank you, Madam Chair. For me, I feel like this is way bigger than just consumer protection. This is a huge public health effort to keep our population well and to make sure that we've mandated access to testing, that anyone can walk in and feel comfortable that they can get a test and not be overwhelmed by the bill. So we don't want to put barriers in the way of anyone accessing testing. And I feel like we're having this discussion about, like, do we set an alarm on the legislative iPhone to remind us to revisit this by setting a sunset clause? Or can we as a body be proactive enough to relook at the law when it's time to relook at it, when we think that perhaps things are better and over and we can repeal it? But I'm not in favor of putting a sunset clause into this bill, because I think that it waters down the goal, which is public health.
Representative Matheson.
Just wanted to mirror Senator's statement. I think it's really important not to lose sight of how difficult it was for many of my patients to get a test for COVID. Now we still have had some difficulties with having positive patients that come into my clinic to get a screening for COVID. And if there's any barrier where I can lift that for a patient that's presenting with symptoms, I'm going to try to, I'd really want to support that. And I do mirror the statement that we don't want to lose sight in the public health and prevention of people getting sick by putting a barrier in there where people can't get tested, especially when we get into a situation where it's an emergency. So thank you.
Yep. Are there other comments? Okay. So at this point, I want to suggest, unless anybody has any other parts of LD1 that we want to talk about, I'm gonna give that a minute. All right, seeing no hands raised, I'm gonna suggest that we caucus for 15 minutes. Representative Morris and I can keep in touch if we need more time than 15 minutes. Certainly let me know. And that we would come back ready to vote on LD1, or I guess if there are concerns, ready to discuss any particular issues that might arise during caucus. And then we would do that and then go straight into our budget discussion and hopefully be able to wrap up most of our work this afternoon in time. All right, so let's plan to be back here right at about 3 o'clock. Okay. All right. Okay. I have not heard from Representative Morris that they need more time, so hopefully we'll be getting started soon.
Did you text him, Heather?
I'm doing that right now.
Okay. Because I can if you don't.
just to update everybody, I haven't heard from our colleagues, so I assume they're just still caucusing. So we'll continue to be on hold. Great. Okay. I'm going to give folks a minute to get back. If you can hear my voice, come on back and pop your video on so that I know you're in the room. Okay. We've got a couple people missing, but that's okay. I assume they will join us. Representative Morris, do you have your folks that you're expecting?
Sorry. Yes. Yep.
Okay, great. So with that, we are in a work session on LD1, and Representative Tepler, I'll look to you for a motion.
Thank you, Madam Chair. I move ought to pass as amended with the amendments we just went over in committee.
Including the wake amendment to the language in section A.
Yes.
Great. Great. Is there a second? Senator Brenner has seconded the motion. Is there further discussion before we take a vote? Okay. So the motion is ought to pass as amended. The clerk will call the roll.
Representative Quint.
No.
Representative Quint votes against the motion. Representative Connor.
No.
Representative Connor votes against the motion. Representative Blyer.
No.
Representative Blyer votes against the motion. Representative Morris.
No.
Representative Morris votes against the motion. Representative Matheson.
Yes.
Representative Matheson ought to pass as amended. Representative Evans. Representative Evans, could you unmute your mic?
Yes.
Representative Evans ought to pass as amended. Representative Arford.
Yes.
Representative Arford ought to pass as amended. Representative Millerano.
Yes.
Representative Millerano ought to pass as amended. Representative Brooks.
Yes.
Representative Brooks ought to pass as amended. Senator Stewart. Absent. Senator Brenner.
Yes.
Senator Brenner ought to pass as amended. Representative Tepler.
Yes.
Representative Tepler ought to pass as amended. Senator Sanborn.
Yes.
Senator Sanborn ought to pass as amended. Colleen.
I was just going to ask Representative Morris what the minority report is.
Yep. Ought to pass as amended with everything that was in the majority report with two changes.
Yep.
Sunset on the testing provision and a limit to 180-day prescription for patients with that are stable on their meds with an existing relationship with their prescriber.
So can I just clarify? So you want to end, the sunset would be 12/31/23?
Yes.
Is that what you discussed earlier? Okay.
Yeah.
Just double checking. Thank you.
Okay. So with that, we've concluded our work on LD1, and except that we'll have language review on Tuesday, presumably. We now need to turn to the budget, much of which for this committee I think is quite straightforward and easy. So let's do the easy part first. I'm going to wait for Colleen to get there.
Do you want to do the easy part first? I didn't know if you
I do. I still want to
before
do
the
the easy.
commissioner? Okay.
Yeah, let's just bang it out. I think it is so straightforward. Let's get through the actual report back worksheet that we have to do.
Okay, great. So this is the Appropriations Committee provides a template to the committee, and I'm just sharing it now, and we'll just use this as the easiest thing to use this to go through. But what they do is they ask the committee to take a vote with regard to each of the programs and each of the individual initiatives. And so I've sort of highlighted that here as we go through. So it's useful if we take straw votes on each of these initiatives. For those few programs where there are no initiatives, we have in the past just taken a quick straw vote in support of the baseline budget because The committee does have an opportunity to recommend changes to that if that aren't included in this budget if you wanted to. So you do have an opportunity to either vote these in, amend these in some way by changing some of the amounts or changing some of the timing, or recommend that they be taken out. So we usually do in, out, or amend in terms of our voting as we go through. So if you just want to go through quickly, I'll just take it as the pages are presented. So the first item was within the Office of Employee Health and Benefits, and this relates to the administration of benefit plans. This is an initiative that would add one position to support the office in two ways. One, to support the implementation of a law change that was made last session to allow town academies to join their employees to join as members of the state employee health plan. And then the second piece, there were some changes made to a program that provides health insurance coverage for certain retired county and municipal law enforcement officers and municipal firefighters. And so they're seeking permission to add one position, and that's what this initiative is.
And Colleen, just to clarify for the committee, there was also a
oh yeah, I can
math
point out the
error.
error. Yes.
Yeah.
There is an error here in the accident, sickness, and health insurance internal service fund and in the firefighters and law enforcement fund. So you'll see here, I don't know if I can highlight, but the amount here in all other for both the accident, sickness, internal service fund and the firefighters, where it says 1.591 million roughly, that should read the same in 21, 22, and 22, 23. That was a mathematical error. So when that's corrected, it's overstated. So this 169 million should really read 1,591,383 for both years. And then the corresponding amount down below where it says 51,707, that would be 51,707 in these two columns as well.
And the initiative that we're actually voting on is down below.
Right here. Yep. It's just to add one position, and you'll see
the numbers are down below.
The numbers
we haven't
are right
seen
here.
them yet. Yeah.
Yep. The
Great.
numbers
Okay.
for that are right there. So it's really just the salary and benefit costs, and then any associated all other costs for those that position.
Okay. So I think the best way to do this is to briefly stop screen sharing and take a straw vote so that we don't have to take a roll call on each of these. It's not required. Is there discussion on this initiative? All right, seeing none, please put your physical hand up in your box and the clerk will count the hands. If you agree with this initiative, so it is unanimous of those present, which is, how many of us are there? 10, 11, 12 of us.
Oh, thank you.
Okay, and then we can keep screen sharing and go through in this way, through the easy part.
Great. Okay, so then the next one relates to the Trade Adjustment Assistance Health Insurance program. There are no initiatives within this program, so this would just be a vote to approve their baseline budget.
Okay, so we'll stop screen sharing. All those in favor of approving the baseline budget on the trade assistance? Okay, it's unanimous of those present.
Great. The next relates to, it's entitled the Dirigo Health Fund, but all that remains of the under that is the Maine Quality Forum. So this is an approval of the baseline budget for the Maine Quality Forum. There are no initiatives, so it's just carrying forward their baseline budget.
Okay, all those in favor of approving the baseline budget for the Maine Quality Forum? Okay, it's unanimous of those present.
Great. And here we go. This is the Maine Health Data Organization. And with regard to the Maine Health MHDO, there are no specific initiatives, although I will note on the next page, there's a language piece, but for here, it's just would be, the vote would be to approve their baseline budget.
Okay. And all those in favor of approving the baseline budget of the MHDO? It's unanimous of those present. I think they showed the value of that during our presentation today quite well. With more value to come soon.
Right. And then I'll just quickly, since we're talking about Maine Health data, it's actually at the end, but there was one language piece related
Let's skip to that.
MHDO, fine. Which is on the last page here. And this is just an authorization for them to transfer money between the personal services account. I believe there's some authorized but vacant positions, would authorize them to move that to all others so they could use that funding for some of their contracts with consultants to assist them in completing their work. This similar provision, such as this, was included in the prior biennial budget, and they're seeking authorization to continue that in this budget.
Okay, all those in favor of the language change in part DD? I just need you to stop sharing for a sec, Colleen.
Stand in. Thank you.
Okay, hands up in the window, and it's unanimous of those present.
Great. So now we're back to the budget items related to the Department of Professional Financial Regulation. And I know that the committee had some follow-up questions for the commissioner. I don't know if you want to start going through the initiatives now or hear from the commissioner who I thought was here and I hope is still here, or how do you want to proceed?
Yeah, she is here, so we're good. So I think it makes sense to probably bring in her at this point, but then I want to continue to discuss the provisions in order as they rise. So we'll bring her into the meeting. We can bring in Mr. Lund as well. In case we need him.
And that'll be the first one. So.
And yeah, exactly. So let's do that, and then we can switch back to screen sharing and see if there are questions.
Okay, great. So these next pages, or all the rest of the pages, really relate to programs and agencies within the Department of Professional Financial Regulation and or some of the affiliated health licensing boards that we heard about at the public hearing. So the first agency is the Bureau of Consumer Credit Protection. There are a number of initiatives within the Bureau of Consumer Credit Protection related to the addition of new positions. And the commissioner's testimony indicated that some of those positions would be funded in part by an increase in fees, and the follow-up information she provided by email gives some background information on the anticipated revenue from those increased fees. But each of the initiatives here, again, would be voted on by the committee. So the first one in the middle here is a initiative to establish a deputy superintendent position, not this fiscal year, but in the second fiscal year of the biennium, and you'll see the amounts associated with that position here.
Okay. And we received a table of the proposed fee increases.
You did. Do you want me to pull those up?
Would the committee just have any members of the committee that want us to pull that up? Let me know. If you've already looked at it, then we don't need to take the time to do that, but just raise your hand, your electronic hand, if you'd like us to pull that chart up. All right, I don't actually see any hands up, so I think I will consider that that the committee has taken a peek at it and that nothing looked amiss. So at this point, I think we can stop screen sharing and take a vote on this initiative.
Great.
All those in favor of this initiative for the consumer credit, what is it called?
Consumer Credit Protection, Deputy Superintendent position.
Thank you. It's been a long day. All right. Representative Evans, is your hand up as well? Yeah, great. Okay. It's been such a long day that my headphones keep running out of batteries one at a time. Okay.
Okay, so in addition to that staffing change, there were other staffing changes suggested in the budget. So this next initiative would establish one consumer credit examiner position in the first year of the biennium, and then add one additional position in the second year. So you'll see the personal services and all other amounts associated with the one position in the first year and then the 2 positions in the second year.
Okay. Are there any comments on that part of the budget? Seeing none, all those in favor? Okay. It's unanimous of those present.
And I should say, if you have any specific questions, Lauren from the Office of Fiscal and Program Review is here too. So if I can't answer them, she can. So I didn't see her here before. So I'll go back to sharing.
Thank you.
Yep. So the next initiative here, again, is 2 more positions that would be proposed to be added in the licensing division. And again, all of these positions are proposed to be added as part of a reorganization of the Bureau. So you'll see here the associated personal services and all other costs for these 2 additional positions.
Great. Any comments on this part of the budget? All right, seeing none, all those in favor? Okay, it's unanimous of those present. I told you guys this was going to be easy.
It makes it easier when it's other special revenue, I think, right?
Yes, definitely.
So those are the initiatives with regard to the Bureau of Consumer Credit Protection. So that was it for them.
Okay, so we can push Mr. Lund back into the attendees.
Yes, we can.
Thank you, Mr. Lund.
The next is the Board of Dental Practice, and there were I think an initiative with regard to the Board of Dental Practice reflects a reduction in their anticipated funding that they provide to the Office of Attorney General for services to the licensing boards. You'll see when the numbers are in parentheses, that indicates a reduction. So a slight reduction in both years of the biennium.
Okay, all those in favor? Okay, it's unanimous of those present.
Great. That was it for the Board of Dental Practice, and now we're moving on to the Bureau of Financial Institutions. There are no new initiatives associated with the Bureau of Financial Institutions, so this would be just a straw vote in support of their baseline budget, which the amounts are shown here.
Okay.
Stop sharing.
All those in favor of the baseline budget for the Bureau of Financial Institutions? Okay, it's unanimous of those present.
That brings us to the Bureau of Insurance, and there are several initiatives here. The first is a reflection of funding for increased costs as a result of higher state cap charges. We talked about what state cap charges are. They're rates that are charged to each agency to help pay for the centralized services that are provided among all agencies of state government. So this is an allocation recognizing an increase in those rates that the Bureau of Insurance is required to pay.
Okay. All those in favor of the state cap initiative? And Representative Quint, are you with us? Thank you. All right, it's unanimous of those present.
Great. The next one here is, again, it both reflects an initiative for increased professional services contracts. So this would authorize or allocate funding within the Bureau's resources to provide for outside contracts and also related state cap charges associated with those contracts.
Okay. All those in favor? It's unanimous of those present.
I think that was it for the Bureau of Insurance for initiatives. Now we move on to the Bureau of, the Board of Licensure in Medicine. And the first initiative here relates to funding for cost increases associated with services provided by the Office of the Attorney General. So there are some increases in each year. And again, this is an authorization allocation of their other special revenue funds.
Okay. All those in favor? All right. It's unanimous of those present.
And this next one is an initiative associated with the establishment of an additional commission member. And that, I think, is a reflection of the addition of a physician assistant member to the board as a result of some of the legislative changes made last session. So this provides some of the personal services or the expenses that are paid to that additional board member.
Great. All those in favor? Great. It's unanimous of those present.
Thank you. And that is it for the Board of Medicine. And now we move on to the Board of Nursing. And I know that Representative Tepler had asked some additional follow-up questions about the director position, and that was included in Commissioner Head's memo back to the committee. So the first initiative relates to the reclassification of the director position. So it both includes some retroactive costs and then the ongoing additional personal services and all other costs associated with that position.
Representative Tepler.
Thank you, Madam Chair, and thanks, Colleen. I simply want to say that I was completely satisfied by the information that was sent to us by Commissioner Head, and that I am comfortable with the relative nature of the salaries of the executive directors.
Great. Okay, that's an easy one too then. All those in favor of this initiative? Great. And we thank Commissioner Head for providing that information prior to the work session.
Great. So that was the first one. The second initiative relates to funding for increased costs as a result of higher state cap charges. So you'll see a little less than $10,000 in each year of the biennium associated with those increased costs.
Okay. All those in favor of this initiative? It's unanimous of those present.
Great. Moving right along to the Office of Securities. There were a number of initiatives here, but the first one is a reflection of increased state cap rates.
All right. All those in favor? It's unanimous of those present.
The second one relates to funding for increased cost increases associated with services provided by the Office of the Attorney General. And you'll see the amounts there.
Okay. All those in favor? It's unanimous of those present.
Oops. Okay, I don't know why that's coming. Okay. The next one here provides funding for witness fees, expenses for judicial proceedings, and related state cap charges associated with those. This relates to 8 pending investigations and the related expenses for preparing for those judicial proceedings.
Okay. All those in favor? Great. I think it's unanimous of those present. Representative Evans, we didn't see your hand. Now we do. Great. So it's unanimous of those present.
Great. The next one is a allocation to provide funding for additional professional services contracts in the Securities Investor Education and Training account. This would allow the Office of Securities to partner with universities, Finance Authority of Maine, and other entities to promote cybersecurity awareness and the prevention of fraud.
Okay. All those in favor? Great, it's unanimous of those present,
Great.
which is still 12.
Get back here, that's right. This next one is provides funding for additional cell phone services, portal fees related to online licensing, and related state cap charges.
Okay, all those in favor? And it's representative, there we go. Okay,
Great.
it's
I see
unanimous.
yes, thank you. We got a few more for the Office of Securities. This one reflects funding for increased rent. Was higher than what was previously budgeted, so this is the allocation for those funds.
Okay, all those in favor? And Representative Evans,
Oh,
there you go.
it is.
We're
Great.
unanimous.
Thank you. The next one here relates to provides funding for increased general operations costs to align with current expenses. This relates to their need increases associated with online database subscriptions, credit card fees, and you'll see some of their dues as part of participating in some national associations as well. I should note, you'll see under the initiative, there's a justification statement that explains further as to why the initiative is needed. So when I provide some of the rationale, that's where that's coming from.
All those in favor? Okay, it's unanimous of those present.
Great. All right, then this one at the bottom of the page relates to increased travel costs related to examinations. And this is for in-state travel.
Okay, all those in favor? It's unanimous.
Great. That's the offices, all of the Office of Securities, and then we have two more licensing boards, the Board of Optometry and the Board of Osteopathic Licensure of Medicine. So the first is for the Optometry Board, initiative reflecting increased rent costs.
Okay, all those in favor? Great, it's unanimous of those present.
And then the next initiative for the Optometry Board relates to increased costs as a result of higher state cap rates.
Okay. It's unanimous of those present, I say before everyone raises their hands. Okay.
We are going through this quickly. Great. I saw everybody on that one, so thank you. And then the last initiative for the Board of Optometry relates to cost increases associated with services provided by the Office of Attorney General. And then you'll see those amounts here, at the top of the page.
Okay, all those in favor? Great.
Great. And the last one is, whoops. The last is the Board of Osteopathic Licensure, and their first initiative is associated with cost increases for services provided by the Attorney General.
Okay. All those in favor? Representative Morris? Okay. It's unanimous of those.
Got everybody, and that's it. Thank you very much. Okay. I appreciate it. That's all the budget documents, and I know that you could hear.
We want to have some additional conversation. Representative Bleier has his hand up though, so we'll start there.
Yeah.
Thank you, Madam Chair. Colleen, would it be possible to give me a budget over budget increase with all the items that we added on today? Is that
Yes.
possible?
Yes, yep. You can see, I'll show you. You can see in the budget documents at the, just as an example, this is the Board of Osteopathic Licensure. The last program summary amount on each of the pages, you look at 2021 and 2022, that includes both the baseline budget and all of the initiatives. So that will be the total. So that's where you'll be able to see for each of them, you know, what the, if the initiatives proposed in the budget go forward, that will be their budget for the next 2 years of the biennium. But I'm happy to break that out for you, you know, in a chart form or an email, so you can see just the totals for everything.
Thank you. I would appreciate
Although,
that.
Sure.
Yeah, and just to specify, these are allocations as opposed to
Right.
appropriations.
Yes, I'm sorry.
Because they're all
missed
other
that.
special revenue. So
Right.
there's no general fund appropriation for any of this.
That's
It's all
right, there's
just
none.
allowing the agencies to spend the money that they have collected directly from licensees or permittees or users in some way.
Yeah.
Senator Brenner.
I could do that.
Thank you, Madam Chair. I just have a question, and I know it's late, so I don't want to hold everyone up, and maybe I can get an answer later. But I'm just curious why we have a Board of Medicine and a Board of Osteopathic Medicine, why we wouldn't just have one and both bodies get certified or licensed under the same board. Seems duplicitous.
It's a great question that perhaps
It's been
for
talked
another
about
day.
Before, yeah, it's been talked about before. It just hasn't happened yet. It's been considered by the legislature.
Thank you.
Mhm.
There's always a historical rationale. And the director of the Board of Medicine was here earlier, but he has left, so I won't ask him to weigh in.
Yeah, I should say the assistant director's here if you wanted to have him weigh in.
I think it's okay if we just move on. Senator Brenner.
Maybe I'll email him. That's fine.
Okay. All right. Thanks. So I do want to talk with Commissioner Head about, as I mentioned during the presentations earlier this week in front of AFA, sort of a different page of her budget that isn't in front of us because there are consolidated boards that are administered directly and that go to the IDEA committee in the budget documents. And Commissioner Head, you sent us some information. I have to admit, we've been on the Zoom calls all day, so I haven't had a chance to carefully review that information. Colleen, it may make sense for us to share some of it.
I can do that.
I can imagine that our committee hasn't had a great chance to look at any of the documentation that Commissioner Head might have put together. But I guess to frame the issue, there was a letter signed and released to the press complaining to the Attorney General about delays in licensing for mental health providers during the current pandemic. And I think Commissioner Head, I want to give you a chance to sort of address that, but also we're in a budget context. And what I really want to figure out is whether the workload has increased and you need to ask for an additional allocation or a reorganization of your staff in some way in order to address the backlog and ensure that we are quickly licensing new mental health providers.
Thank you, Senator Sanborn and members of the committee. I know it's late, but this is important information, and we've worked for the past 48 hours to bring you some preliminary information on what we see. I want to explain how we got to the information that I've provided today. The first thing we did was to look at we created a chart of all of the individuals who signed the letter to see exactly what we had in front of us. That was our starting point. We can now see, we've done the history of each of those individuals to see where their particular issue arose. And we can see based on our licensing records that the majority of people who signed the letter are in the counselors area. There were a few social workers, a few alcohol and drug counselors, and no psychologists. So we can see that the program of counselor licensing is a focus of the people that we are held to serve, both for the public and our applicants and licensees. So this concept of licensing counselors is complicated. It is probably one of the most complicated licensing processes that we have in the Office of Professional and Occupational Regulation. Of the 50 individuals, we can see that 20 of them have had incomplete applications at one point or another during their history as a licensee. Of those 20, 16 were in the counseling field. So that reinforced the fact that we're going to be looking carefully at the counselor licensing program. The other thing that we discovered was that many of the issues that I think these individuals are referring to happened in past years. And I think that's important because in 2018, we moved this licensing program from a paper process to an electronic format so that all applications for initial licensing could be done online. That has been a successful transition. So what we did with the chart was to take all of the applicants that showed a problem between 2018 and 2021. So we isolated those individuals, not for the purpose of doing anything except trying to figure out where the weights are in the process of licensing in this profession. And I'll go now to the memo that I provided to show that there are actually 8 different licenses that one can obtain from this licensing board.
Colleen, do you want to share that memo so we can follow along? I think that would be helpful because I have some questions about the examples after we get through the initial part of it.
So there are 4 different kinds of counselors, and each of those 4 different kinds have a full license and a conditional license that is the initial license for that aspect of the profession. Each type and level of license has requirements that have to be met before the license can be issued. Conditional licenses are typically the first level of licensure to be held. And during the license term, the licensee gains experience, supervised experience, and knowledge in order to take an exam to get to the next level of licensure. So an application has to be filed, and it must include all required documentation for each type of license. So what we have done here is put together a sequence just for the purpose of explaining the process itself. And in each step, I'm going to identify where there is a time gap that we need to understand. So the initial application, when that is received, an electronic license record for the applicant is opened. The application if the application does not contain all required documentation, it is considered incomplete. That's an important word because what it means to us is that we can't really move forward with that applicant until we receive the required documentation. When we receive it, it's then added to the file.
Commissioner Head, can I interrupt you there? What is your current time frame from receipt of the application to initial review for completeness?
That is not information that I have today. The staff is continuing to work on those schedules.
Okay.
So I understand the question and we will answer that.
Okay.
But it's variable.
I'm sure that it is, but it looked like that might be one of the gaps, judging from the examples that are at the end of your memo, where there wasn't information about when the initial email requesting additional documents was sent. So it's not clear to me whether the applicants sat on the request or whether the request was not issued for many months. And that's a bit vague in the memo. So that's the question that I would like to, and we can circle back to this for sure after you guys do some more digging. Representative Tepler, I see you.
Thank you, Madam Chair. And thank you, Commissioner, for being here. I'm just curious, does the application itself, since it's an electronic application, indicate to the person who has submitted it that it is incomplete, or is that all done with review by staff?
That is done by review of the staff. When they come in the morning, there is an inbox with incoming applications. They address those applications that day. Unfortunately, many of those applications, depending on the kind of application we're talking about, are incomplete. Yep. So the staff at that point sends an email to the applicant listing the missing items. That's when the waiting period starts. We wait for that applicant to supply us with the missing documents.
Oops, sorry. Sorry. Couldn't that problem be resolved by having the online application itself indicate to the applicant that it is incomplete? I mean, that's something that I've experienced in other applications that I've done online where it tells me, you know, you didn't upload X, and so your application is deemed incomplete.
I would like to get back to you with that information because we do use checklists for each application. So there is a checklist. That's what is sent to the applicant. I understand that you're suggesting something right online that should catch them, that you haven't uploaded that particular item.
Yes.
We don't stop an application from being submitted for that reason. There are different kinds of applications that we want in hand at the earliest possible time. But some applications are submitted too early. And I'm quite sure that the applicant knows that it's not complete, but wants to submit that application. Not in all cases, obviously, but there is some, the attitude of applicants to the application process is different for each person, especially when someone is graduating from a program that's required for a particular license. And maybe in this case, we should move right to the examples, because I think that gives you a better sense of what's happening.
Senator Brenner has a question as well, Commissioner, if you wouldn't mind.
Sure.
Senator Brenner, go ahead.
Thank you, Madam Chair. Thank you, Commissioner Head. My question is, can we assume that when you're speaking about folks that are applying for their license, that we're talking about new grads, or are we talking about folks that are coming from out of state who've already been practicing? And is there any reciprocity in that licensure from state to state currently that would shorten the process?
Right, that's an excellent question. People who are licensed in another state in this field who want to practice in Maine and are licensed in another state can apply for licensure through the license through endorsement process. We give them credit for having that license in another state. and the process is much shorter. What I'm talking about today are all Maine graduates, people who want a particular license to practice but need a conditional license to gain the experience and supervision that is required in order to move to the next level, which would be the full license. So it is, ironically, it's much easier at this point in time for an out-of-state professional with the same license to be licensed in Maine, as long as they don't have there are certain restrictions or limitations that we need to check on. But generally, it is easier for the out-of-state licensee to become licensed in Maine. It may have been more difficult for them in their home state to achieve the license that they ultimately have. And I think that's the same for Maine applicants who are here in Maine, want to stay in Maine and practice in Maine. I think one of the reasons for this is that the program itself was created, the license program was enacted by the legislature in 1992. It is a young profession, and there are many different pathways to becoming one of the 4 kinds of counselors that we issue licenses for. So there's a variability in what is required, and I think some of these examples will show that. So in answer to your question, there are 2 different groups, and they have a different experience to obtain a Maine license.
Thank you.
I'm sorry, I thought someone had a question. Going to the first example, an applicant files an incomplete application for a conditional clinical counselor exam and licensure on May 14th, 2018. Correspondence is sent to the applicant requesting the information needed to complete the application.
So Commissioner Head, I think what I was asking for was the date of that correspondence.
Well, I will certainly get that for you. That's
great.
That's not the information I have today. I'm trying.
I understand.
Yes, the basis for moving forward, but I do understand. So there was a gap there. I think you'll find that the date that we sent the correspondence is pretty close to the date that it was submitted, but I will verify that. On July, the information is received, the application is complete, and the exam approval letter is sent to the applicant. On November 7, 2018, the applicant passes the exam. The applicant is notified of the passing score and is asked for the proposed supervision plan so the license can be issued. That is a requirement.
And so similarly there, I would ask for the date of the correspondence of the notification,
Right.
just so we have a full timeline of how quickly things are getting turned around from your office.
Okay. The supervision plan is received April 8th and the license is issued. In this example, it probably looks like it took 11 months to issue a license, but because the initial application was incomplete, the exam could not be approved until approximately 6 weeks after the incomplete application was received. Once the applicant received notice of approval to take the exam, the applicant passed the exam 4 months later. 5 months after passing the exam, the applicant submitted the proposed supervision plan needed to issue the license. So there are times when we are in a waiting stage, and it's up to the applicant to do his or her part of the licensure process.
Representative Tepler has a question, so I'm going to interrupt you there.
Thank you, Madam Chair, and thank you, Commissioner. Commissioner, I'm wondering, we've been grappling with these supervision plan issues in a number of licensing situations. And do you have a sense of how difficult it is for an applicant to establish a supervision plan? And do they have to pass the exam before they can even begin to establish a supervision plan? So I'm wondering whether part of it is the requirements and not just the processing of the application, but the difficulty, the roadblocks that are maybe established by the process itself.
I don't want to speak for a board. I'm only here to tell you what we see in our licensing files. That is something that can be relayed to the board, and we could get an answer from them on that. I think it depends on the applicant. Many applicants are very motivated. They know that their exam is coming. They've already made arrangements for their supervisor. It may be someone they've had as an instructor in their program, but not every applicant is the same. It just depends on their personal circumstances, how motivated they are. We take applicants as they come to us. And, I think that there are times that the staff has come to me and said, I don't know what I'm doing wrong. I have an applicant on the phone. I've explained everything about the application itself, and the individual applicant wants me to stay on the phone with them while they complete the application. So every applicant is different, and we try to accommodate their needs as they come to us. But I think over time, between 2018 and 2021, factors have increased the workload. Maybe temporarily, maybe not. But I have a chart that I think I forwarded to Colleen that shows the increase in numbers of.
That's great. Let's turn to that chart if we can, Colleen. Yeah, perfect. Thank you. Can you make it bigger for us? Great. So this is great, Commissioner Head, because it really gets to the crux of my question as we're here in a capacity of looking at the biennial budget. We don't know if you have initiatives to increase or improve the staffing for counselor applications in particular. We don't know if you have that because we haven't seen that page of the IDEA committee's portion of the biennial budget. So perhaps you could just speak to whether you have an initiative there, or whether in light of this letter and the review that you guys have done over the last few days, that might be part of a change package or something that we should recommend back to the AFA committee.
Yeah, thank you for that. I am not at a point right now. So let me just answer the question. Are there initiatives in the other part of the budget? There are not. I did not request new positions for this unit. There are 5 people in the unit. That is one of the largest units that we have. And they are well trained and they work hard. So I anticipated the extra workload in the emergency temporary licenses that you see here on this chart in 2020 for each category of mental health counselor. Those are high numbers, and we are getting pressure right now for those emergency temporary licenses to be made permanent. Obviously, that is not anything that a licensing board could do on its own. That is the legislature's role. But I think every state is going through the same growing pain of these emergency temporary licenses. Those will eventually turn into something else. My focus really is on what we are doing for our main applicants and licensees. And so that's the work that we have started here. So no, I have not asked for any new position for this unit. If after this analysis is completed, I feel that we need more help, I will have to consult with the governor on that. If necessary, it could be added to a supplemental budget. I think that we can get through this period of expanding need for mental health professionals. With the staff that we have, there are things that we can add to the program that will make it more robust. So I think that's all I can say in answer to your question. Are there other initiatives that you aren't aware of? The answer is no. It's certainly on my mind after it was raised, and I will continue to look at this. And at the point at which I feel that we actually need an additional staff person here, I need to consider how long it takes to train someone to be efficient and knowledgeable in this area. It is complicated. The people that we have now are experienced. And so I guess I'll stop there, and I will continue the work that I'm doing with the staff and come back to you next week. That's my plan.
Okay, Representative Matheson.
Thank you so much, Commissioner. I just wanted to make sure that I was clear about the numbers, and these are really helpful, and quite a few temporary licenses, obviously. So if I understand right, the 50 complaints are not within the emergency temporary licenses, correct? These are just these are new main. And do you think that because of such a high rate of emergency licenses, that's why we were in a situation where we got into with the 5 people?
I have no idea how the 50 people came to sign that petition or whatever it was. I have no knowledge of that. I guess what I'm saying is you may view the letter signed by 50 as a huge problem. From my perspective, between 2018 and 2021, there may be delays, but it is not, what I see is not what the letter implies. And I don't mean that in a negative way. I just think we have license information that shows that we don't control everything as a board staff. We depend on applicants to be prepared to complete their applications. I want to say a word about the exam process because this is important. I got a letter from someone who contacted the governor's office, and she said, I waited 45 minutes online to sign up for an exam. I think that's outrageous. And I said, you must realize that you are in contact with the National Council for Certified Counselors. That is the exam owner, and that's who you need to register with to sign up for an exam. You're not signing up with the board. So whether that isn't well understood, we can certainly make it clear. We have documents that we provide to applicants to make it clear that they need to register with the NBCC to take the exam. Those exams are being scheduled out for 2 months by the exam company. The board doesn't have any control over that. They're doing it for COVID protection reasons because these folks have to go to a site where the exam is given. And of course, there aren't as many slots right now. So there are lots of things coming together in this review, in this study, that I want to get a better handle on. And the reason I'm here today is because I thought it was important to let you know that I consider this an extremely important work for my staff and I to work on together and to report back to you what we find. And I think it's going to take a little bit more time to get a better handle on the actual facts of each applicant's experience between 2018 and 2021. So that's really the essence of what I wanted to talk about today. I know you probably have questions because you have experienced a professional licensing situation that may be very different. I see questions.
So thanks. I apologize for my background. I've hidden in my basement away from 3 barking dogs. And, you know, I really appreciate that you are digging into this and that you're, what you're bringing to us today is preliminary. I know I have another meeting at 4:30 that I'm trying to run to, but it has been a fruitful discussion and the memo was very helpful. It will be more helpful with some of that additional timeline information about when the correspondence from your office went out. So Representative Arford, Representative Tepler, do you have questions that we should address today before we adjourn? Okay, Representative Tepler, go ahead.
Thank you, Madam Chair, and thanks again, Commissioner. I guess I want to get a sense from you, Commissioner, about whether or not, regardless of the pandemic, there are bottlenecks in the process that maybe have nothing to do with your staff and may have to do with the process itself, and whether or not this is something we need to address, because we face a shortage of mental health professionals regardless of whether we're in a pandemic or not. It's been exacerbated by the pandemic, but I think that I'd just like to have a better sense from the board, maybe even, of where are the bottlenecks? Are they just dependent on the individual applicants, or is there an issue with it being more difficult in some areas to get supervision? And just overall, how long the process might take for a motivated individual, recognizing that some are more or less motivated.
I appreciate the question and I agree with you, and I would like the same information that I'm going to give to you. I do feel that there are obstacles, not on either side, but the process itself is not intended to be a 2-week wait time for a license. This is a mental health license that takes time to qualify for, to pass the exam, and to apply for the final license. I think ideally, for all of the mental health areas other than counselors, I think a 2 to 4 week license period is doable. Counselors is not going to be that quick. I would say 5 to 6 weeks is probably the best scenario. And I want to come back to you and explain why.
That would be great. That would be very, very helpful, particularly if we've got individuals who aren't actually adding to their skills because they're not able to work in any capacity because they've graduated and then are waiting for this long period of time in order to be able to start their professional career. So it will be really helpful to have you come back. Representative Arford, I noticed you put your hand down. So
Right,
great, perfect. Okay. So I really appreciate that you were here on short notice to help us understand this, and we will definitely have you back again, perhaps on Tuesday, but perhaps later, depending on how long it takes to pull together additional information for us.
And I'll check with Colleen on that.
Great. Representative Arford, now you have your hand up. Go ahead.
Thank you, Madam Chair. And my quick question is, I'm not sure of the time frame during which all these complainants were complaining about, but I'm assuming, predominantly during the period of the pandemic. And so my question was, I'm assuming at least some of your staff, if not all, were working remotely during that time period. Is that correct?
It's a combination of in-office and
My
remote.
question is if you're factoring in the fact that they were not in their normal working environment in this assessment, if that's being factored in at all.
I will certainly consider that. At the moment, we're looking at our licensing files and all of the information in our database.
And the final thing is, I want to thank you, Commissioner Head. Your willingness to be transparent and upfront with us is greatly appreciated.
I thank you very much. I appreciate that.
Yep, I would second Representative Arford's comments, and you were well prepared to address this within 12 hours or whatever it was after it broke in the media when we had our hearing on earlier this week as well. So I appreciate that you've been on top of it, and we will, I think, put a pin in this and come back and hear more in the future. So with that, if there's no objection.